we're live on YouTube.
Yeah,
Good.
absolutely. Okay.
Yes, yes, please.
Good evening, friends. Welcome to Indian Arthroscopy Society webinar. This is a very special webinar because we have friends from UK, Germany, and France joining in. In addition, our Indian faculty, Dr. Bhushan. Let me thank Bhushan for arranging this webinar at a short notice of time and to bring in the world leaders in osteotomies together on a single platform. It was difficult, but I think Bhushan managed to get time from each one of these guys. Bhushan knows them personally as well, and I think I would ask him to introduce the faculty and their specialities, and then we get going with this webinar. I believe you guys have been looking forward for this meeting for a long time, and we feel that you will really benefit much out of this meeting. So Bhushan, if you can just introduce our esteemed faculty today. Yeah, Bhushan. Sandeep, Bhushan, can you ask Bhushan? Bhushan, are you? Hello?
Yeah, he is again.
Yeah, is he muted?
IPS, you can introduce first speaker and
Yeah.
start.
Hello.
No, Bhushan
Yeah,
is going to start. So, yeah, sorry, Bhushan. Yeah,
So can you all hear me?
yeah, we
Yes.
can, Bhushan.
Yeah. So good evening, all. We are really lucky to get. So we are really lucky to have a really fantastic group of people who are going to introduce us about the world of osteotomy and how osteotomy stands as a major surgery in today's world. I was lucky enough to work with most of them while I was working abroad, and not only they've been my ex-bosses, but I've become good friends and colleagues, and it gives me great pleasure to introduce the speaker after me, Rags Khakha. Rags Khakha is a colleague of mine. He's a brilliant surgeon and is a complete knee surgeon, works in London, and what we call as a brilliant pair of hands. The speaker after that is Kristian Kley. So if there's any surgeon that you would want to get inspired by, I think it will be Kristian Kley. His amazing surgical skills makes everything look very easy. It's only when you start doing it, you realize it's quite difficult to do things his way. But he's a brilliant surgeon. Matthieu Olivier is a brilliant guy and has developed a keen interest in the patient-specific instrumentation for osteotomies. And I've seen him present before, and it's amazing to see what technology advancements have achieved in today's practice. Matt Dawson is the head of the chief of osteotomy ESCA, and I worked with him in past while in UK, and he's going to share a lot about complications of osteotomy. These are some of the surgeons who have maximum experience of osteotomies in Europe, and they will tell you about all the nitty-gritty and ins and outs of osteotomy. Lastly, my very close friend and ex-boss Adrian Wilson, Professor Wilson, is brilliant with his own take on osteotomies, and he's going to talk about different complex cases, and he's actually going to show the power of osteotomy as a surgery. Adrian needs no introduction. He's a brilliant surgeon and has moved from Basingstoke to London now, and is as a renowned surgeon there, practicing doing complex surgeries with Kristian and Rags now. So welcome you all, and let's start with the basic stuff. I'm just going to give a brief introduction about evolution of osteotomy as a surgical tool. So let me start sharing my screen. So what's the need to understand evolution of any surgical technique? It's important to learn from the mistakes that our predecessors did to avoid repeating them and learn how to improve yourself and improve the results of a technique. So here goes about the osteotomy as a surgery as we know from the beginning. Every time you talk about any medical technique, surgical technique. You talk of Hippocrates, but it seems that osteotomies have predated Hippocrates as well. There is a mention of a corrective osteotomy in a papyrus found in Egypt in 600 BC, the so-called Edwin Smith papyrus. No, Edwin Smith did not reside in Egypt in 600 BC. It's a name of an archaeologist who found the papyrus, and it's named after him. But we all know about Hippocrates as has had something to say or something to do about various techniques of various surgeries as such. If you look at the timeline about popularity of the osteotomy, it goes up and down based on how things have changed. So we have the time of primitive era or the early era, which is from BC to pre-1800. That's where Hippocrates techniques were followed. That then followed the era of understanding or enlightenment, which was the time of Langenbach, Matthieu, and Barton, where osteotomy as a surgery, as a surgical technique was developed significantly. Then the era came of closing wedge osteotomies, which was 1940 to 2000, followed by the present era, which is the medial opening wedge osteotomy era, right from the time of John Collo Pudu, Dror Palais, who described the principles of deformity correction and the pioneers of opening wedge osteotomy. I'll talk about this later. There is a second graph I have plotted in the middle, and that graph corresponds to the advent of a total knee replacement. In 60s and 70s and 80s, when total knee replacement burst in the horizon, osteotomy took a major hit, and everybody went to total knee replacement, and numbers of osteotomy went really down. This was also compounded by the poor fixation and results from closing wedge osteotomies. But things have changed a lot, and now we are seeing a resurgence, especially in last 10, 15 years. We're seeing more and more numbers of HTO as such. So Hippocrates had devised an instrument such as this, the so-called scamnum. Looks like a medieval torture device, but that was used to correct various deformities as such. And same thing was followed by Celsus and Galen in Greco-Roman period. Let's not waste time on this. Let's fast forward to time of Barton, who did the first corrective osteotomy for limb deformities. Not many people know this, but he is the pioneer of arthroplasty. And pictures such as this find a common reference in literature in late 1800th century. Even then, it was known that genu valgum is usually caused by femoral malalignment, tibial malalignment. So despite not having x-rays, they still had a good understanding of the location of deformity and how to correct it. Wars have played a major role in advancement of various surgical technique. And this surgeon is Langenbach, the same surgeon who's created with creating the Langenbach retractor, is a pioneer surgeon in multiple techniques, actually started doing open osteotomies for removing bullet wounds in the bone. So he used to excise the whole piece of bone in a wedge shape to correct the deformity and to avoid any infection. But still, because of lack of aseptic techniques, there's still a high chance of infection and death. This is the surgeon that we can safely call as the father of osteotomy. It's Professor Matthieu from Glasgow actually published the first textbook of osteotomies in 1880, where he described about 1800 cases with a very few complications. He was the first person to describe his own osteotome. He's first to describe bone graft techniques, and funnily enough, most of his techniques still remain in place. This is a rare picture found in 1883. You can see him drawing the distal end of femur and proximal end of tibia with a chalk on a blackboard. And he was a very clever gentleman who described a lot of surgical techniques for correcting deformities. And this book is still available online, so you can find it on Google. So now, starting the 20th century, so in 1934, this was the first slope-changing osteotomy described by A.L. Brett in Boston. And if you look at it, that's exactly how we still do slope change. Of course, we go a bit more distal than this now with presence of fixation techniques. But at that time, just putting a plaster sufficed in correcting the deformity as such. Now coming to the modern era. Modern era is 1940 till 2000. That's the early modern era. So that was a time when dome osteotomies and closing wedge osteotomies came into vogue. Dome osteotomies were quite attractive to most people, but had a major problem of unstable fixation and a failure rate. Coventry, however, was created with creating his Coventry staple and creating the popularity of, or increasing the popularity of, a lateral closing wedge osteotomy using his Coventry staples. Not many people know once again that he was the first surgeon to start total hip replacement in USA. He was the first to advise use of anticoagulants for pulmonary embolism. And indeed, all our joint registries were started by him. So he was the person to start the concept of joint registry as such. But his closing wedge osteotomy made him very famous, and that was a norm in 1940, from 1940 all the way to 1960 all the way to 1990 as such. There are still some surgeons routinely doing closing wedge osteotomies, which essentially involves taking a wedge off from the lateral side of the tibia to correct the deformity. And this is how it looks after correction. Nowadays, we are using a plate rather than a staple for better fixation. But most of you know this person, John Insall, as a key pioneer of total knee replacements. But before he converted, let's say, to TKRs, he's written various papers, especially in high tibial osteotomy for osteoarthritis of the knee. And this X-ray actually shows a 10-year follow-up. Various studies at that time showed really good survivorship. If you look at the study from Fletcher et al., there is about 85% survival at 20 years for HTO. That's amazing at that time. What they're not showing here is the number of complications, which are significantly high. And that was the reason why osteotomies had a bad name. While this was happening in the Western world, on the Eastern side, Fujisawa and his colleagues in Japan had developed the ideal correction point, the so-called Fujisawa point. A simple technique was followed. They did a preoperative arthroscopy and a postoperative arthroscopy at about 6 months to 4 years post-op. And they found that if the correction was at the level of the so-called Fujisawa point, which is between 30 and 40% on the lateral, in the lateral compartment, then the chances of healing of the cartilage ulcer on the medial side was maximum. So it was a very simple way of finding what the ideal correction was at that time. But at the same time, things changed, as I said, in 1968 when first TKR was performed. Initially, TKR and then UKR actually just killed the interest in osteotomy, which was already plagued with problems of fixation failure. There are a lot of pros and cons for opening and closing wedge osteotomy. A closing wedge osteotomy mainly had issue of bone removal and fibula osteotomy. There is about 7% incidence of common peroneal nerve palsy. It of course leads to shortening. And the worst thing is misshapes the tibia for a future TKR, which makes it difficult for further management in patients. And problems of non-union or failure of fixation were quite rampant with the closing wedge osteotomy. And opening wedge osteotomy was a much more attractive surgery, which negates the need for fibula osteotomy or chances of CPN palsy. Of course, it does need a stable fixation, and that was the Achilles heel for opening wedge osteotomy till about 2000. John Carlo Puddu actually had devised his Puddu plate in late 90s, and it seemed to be working perfectly. The only problem was when you have a hinge fracture, it tended to fail. So that was a major issue for Puddu plate. Dror Palais in 2000 came up with the principles of deformity correction, and we got to know about the angles around the knee, the MPTA and MLDFA, and that changed our understanding a bit. We realized that any deformity could be corrected by a closing or opening wedge osteotomy as long as you had a good fixation in frontal plane, sagittal plane, transverse and multiplanes as such. But the new pioneers of opening wedge osteotomy were essentially the people who designed the locking plate principle for opening wedge osteotomy. Tomofix came in 2002 with the first 92 cases showing really good results. Now the fixation was solid, early mobilization could be achieved. There was no need for plaster fixation. The plate was robust enough to take weight of the patient when they walked, and healing was almost given in properly selected patients. And this was a sort of the changing moment for osteotomies. Even a hinge fracture, which was a dreaded complication for most surgeons doing osteotomy at that juncture, could be treated by using the lax screw or the hinge compression technique, as was described by Alex Stobley and Professor Lobenhofer. So opening wedge high tibial osteotomy now became a really safe and comfortable surgery. These are some of my cases using various techniques. That's a NuClip active motion plate. That's a peak power plate. That's an OTC plate. And that's a standard Tomofix plate. So all of these implants now showed good results as long as you followed the techniques. As our understanding increased, so did the interest around osteotomies of the knee. Anyone who's interested in learning about osteotomies, I would recommend reading this book. It's a brilliant book and explains all the basic principles of osteotomy really well. The top half are the pioneers of osteotomy in the world, and the bottom are the leaders in osteotomy just now. And I'm glad to share that we have 4 of those leaders with us today, talking about various techniques of osteotomy and the power of osteotomy as surgery. We have now seen advancements in newer materials. We can now use the polyether ether ketone, which is the PEEK, as a plate material. We have various types of plates available. We have the contour lock, we have the nuclear active motion. The plate size has gone smaller now. Tomofix is still the same, but various new developments have happened over last 15-20 years, which has changed the technique on process of osteotomy. In any case, the procedure remains the same. You need to have a stable opening with possible hinge protection, or making sure the hinge stays intact. And as long as you can show this on your C-arm that you have a hinge intact and an osteotomy mobile, whatever plate you use can solve your problem. What the future holds, Matthieu is going to talk a lot about this, but patient-specific instrumentation, patient-specific plates, navigation, robotics are all going to have a major bearing on osteotomies in future. We are now seeing more and more people use complex navigation surgery. Our incision sizes have gone down. Kristian Kley is going to show a lot about, is going to talk a lot about the incisions that we can do the surgery through. Planning techniques have improved drastically. Rags is going to talk about the planning techniques as well. We now have various bone graft options available. Analgesia has changed a lot, and rehabilitation is much faster. No longer are we looking at patients who needed to take about 3 months off with a plaster now. We are now looking at patients who say, as this gentleman is saying, that I was able to walk within 2 days, drive in 5 days. So this surgery has made a drastic difference in most patients. We have become so confident now that we are doing HTO plus or osteotomy plus now. We are doing HTO plus ACL, HTO plus PCL. We are doing slope changes, derotation. We are even doing TKR with concurrent osteotomy, double osteotomies. This is a gentleman who visited from another country with a patellar tendon rupture, which was neglected, also had medial compartment arthritis. So he underwent a patellar tendon reconstruction along with HTO with a really good result. So we have become more adventurous and more aggressive in managing all arthritic problems around the knee joint. The concept of an ideal patient has gone now. This is a 75-year-old diamond merchant who after surgery in 2 weeks' time is able to walk unaided comfortably at the age of 75 and had complete healing without any issues. This is a sailor who is 2.5 months post-op, who is able to go back to his ship with complete, starting his normal duties as well. So osteotomy has now become an excellent option in joint preservation of the knee joint. The modern fixation techniques work really well. As long as you plan it properly and execute your surgery well, you're going to have a consistent, reproducible, and a good result. So I think that's a good introduction for our future talks. And I would invite Rags Khakha to talk about planning techniques in osteotomy as such. Thank you.
Thanks, Bhushan. That was an amazing talk. And thank you so much for such a kind introduction. I think Bhushan undersells just what an amazing influence he was on my training, and certainly he's a good friend of the team. And thanks to the Indian Arthroscopy Society for allowing me to talk today. Thank you, IPS, for inviting me along. It's a real honor and pleasure to be here today. So I've been given the talk of planning the osteotomy. So as Bhushan said, my name is Rags Khakha. I'm a orthopedic consultant. I work very closely with Kristian and Adrian, and my sincere thanks to Kristian for the slides. All of the European members on this talk today are part of the ESCO Osteotomy Committee, of which Matt is our leader, Matt Dawson, that is. We've got a couple of Matts today. So just a bit by myself, I'm a consultant surgeon based at Guy's and St Thomas's in central London, and I'm part of the orthopedic specialist team. As with my colleagues, I've got a subspecialist interest in managing knee osteoarthritis and knee injuries, and I have a real passion for joint preservation, hence the talks today. This is the view from the office. Boris spent a few days with us not so long ago. This is currently undergoing renovation. And here we are at the front of the hospital on a bright sunny day, which we don't see so frequently in London, but it's looking pretty good. Just a bit about the London Osteotomy Centre. Two of the gentlemen on this slide, Adrian Wilson and Kristian Kley, will be talking today, but we're also joined by Ronald van Heerwaarden. And we're a dedicated team in managing all aspects of osteotomy, and we currently work together out of the Harley Street Specialist Hospital and the London Clinic. I couldn't help but put this slide in of myself and Bhushan, because since we are talking to an Indian audience, this is in Bhushan and I at the London Osteotomy meeting, which we did last year. And this is the long room at the home of cricket at Lord's. So that was fond memories and something we look forward to doing again next year. So this is what a lot of our operating theatres are looking like at the moment. They're empty, we're not able to get into them. And that's all due to the coronavirus. Hopefully things will start to improve again, but it has given us the opportunity to do a lot of learning and come to webinars such as this. So let's get into it now. This is a busy looking desk with all the kit that we need to plan an osteotomy, but no osteotomy can be well executed without a good plan. So the first thing is to make sure that you have a radiology on board to try and work with you in getting the best x-rays that you can to get an optimal planning. Now, as you can see here from this long leg schematic, the patella is externally rotated, and it's really important that the patella is facing forward. So you need to internally rotate the lower limb and have this plane pointing forward. And this is a fine example as to why that is important, because you can see on the right, the patella is initially pointing laterally. And once you centralize it, you get a better idea of the coronal malalignment and the significant valgus. So making sure you have the correct x-rays is vital to any part of your osteotomy surgery. Once we've got the right x-rays, we need to define different parts of the x-ray. So we start off by doing the joint center of the hip. You can do this by either having concentric circles to identify the midpoint of the femoral head, or you can work out the equal radius from the center. Both are very easy and reproducible techniques, giving very similar results. Moving on to the knee joint, you need to mark out the center of the knee, whether you're using bony or soft tissue landmarks. You can see from this, it clearly demonstrates the marks are very similar as to where the center of the knee joint is. I prefer to use bony landmarks as these are more consistent. Finally, but also equally important, moving on to the ankle joint, you can use either soft tissue or bony landmarks. My preferred option is to use the tibial plafond and marking the center of the tibial plafond to find the center of the ankle joint. So now that we've defined the joint centers, we need to define what the joint lines are. These are very reproducible, straightforward techniques. For the femoral condyles, you mark out the distal portion of the femoral condyles by drawing two marks on the medial and lateral side and drawing a line across them. Similarly, you do the same with the tibia. You mark these very consistent landmarks and identify the tibial joint line. And then finally, you move on to the ankle joint. And as I've done previously, I use the tibial plafond for my joint line at the ankle joint. So now we're in a position where we can identify the axes. As Bhushan mentioned earlier, Draw Paley has helped us to look at the way we identify the mechanical and anatomic axes. The anatomic axis is defined by using two separate points on the diaphysis of the tibia and drawing a line through these. And similarly with the femur, using the diaphyseal landmarks, you can identify the anatomic axis. Now with the mechanical axis, you use the points that we've previously defined with the center of the femoral head and the center of the femur. And with the tibia, the mechanical axis is actually parallel to the anatomical axis. Moving on, we can now look at the relationship of these, and you can see with the femur, the mechanical and anatomic axis is usually 7 degrees deviated from each other, plus or minus 2 degrees. So now we've defined our anatomic and mechanical axis, we can draw the mechanical axis from the center of the hip to the center of the ankle and see where it intersects at the knee joint. Where the deviation from the center point is referred to the mechanical axis deviation. And depending on the papers that you read, there is a variable figure for this. Excellent. So now we're moving on to the nomenclature. As with all scientific commentary, it's very important that we all use the same language. And so in lowercase, we define whether we're talking about the mechanical or anatomical axis using the letters M or A. And in this case, you can see here, the lateral distal femoral angle can either have an A in front of it or a M in front of it. But the MPTA remains the MPTA since the anatomical and mechanical axis of the tibia are parallel. This is best highlighted in this diagram here. And for the purpose of this talk, we're going to focus on the mechanical axis, since this is what we are trying to correct. As a mention on side mention, the sagittal axis has become of utmost importance when we are looking at failures of ligament reconstruction. And this is work that Matthieu is doing a lot of work on this, and hopefully we'll be seeing more publications around this. But let's focus on what we're here to talk about today, the mechanical axis. So now let's jump straight into how we plan an opening wedge high tibial osteotomy. We've already defined our mark on the femoral head and the mechanical axis down to the center of the ankle joint. Let's call this the Michelitz line. We then draw a virtual Michelitz line. The virtual Michelitz line is a line that we define, and we have to initially identify where we are going to intersect on the tibial plateau. As Bhushan mentioned, Fujisawa would have gone to somewhere between 60, 65, even up to 70% of the tibial plateau width. And once we draw this line, we take it all the way down to the level of the ankle joint. The next point is to define our hinge point of where we're going to do the osteotomy. Typically, this is the level of the fibular head. Now, this virtual osteotomy will show that we can see from the hinge point, we can see where we are in the distance at the current level of the ankle joint, and where we would like the ankle to end up. So in having done that, we draw a line from our hinge point down to the 2 points at the level of the ankle, from where we are currently and where we want to end up being. And we define that angle as alpha. This is the same angle that we wish to achieve when we're doing our opening wedge HTO. So we define that at the level of the tibial metaphysis, and we label that level in millimeters as to how much we're opening on the medial side, as measuring millimeters is far easier intraoperatively than it is measuring the angles. So now that we know how we should be measuring them, how do we execute it? This is a very nice video that Kristian's put together of how we used to do it. I used to spend a long time, pen and paper, with rulers and protractors, measuring angles, cutting up the bits of paper. And this is extremely time consuming. And since we are all limited by time and we've got more accurate ways of doing this, this has now been abandoned. But you can see we could be here for a while planning this osteotomy. So we've looked at the angles. The final angle that we haven't looked at is defining where the correction needs to happen. Is the varus in the tibia? Is it in the femur? Is it even within the joint line? The old teaching has always been that if you've got a varus knee joint, you need to do the correction in the tibia. But we now know that that is not always the case. We know that it's important to take into account the joint line congruency angle, because beyond a certain tipping point with significant degrees of deformity, the soft tissue laxity exaggerates the deformity. And we are in a position where we would potentially overestimate our correction and end up in a unsatisfactory position. And this was work that was done by Dugdale and Noyes. So this example of a joint line congruency angle of 8 degrees, and ideally we should be aiming for 2 degrees. And so we move on to where do we correct to? This has been the question since the beginning of osteotomy. Fujisawa did some amazing work at looking at where the correction he felt it should be. And as Bhushan said earlier, his point was 30 to 40% of the lateral compartment. And in modern terms, we are talking about the 65 to 70% of the tibial plateau width. And this is the same example that Bhushan demonstrated. And you can see he managed to get excellent correction, but it's very much far into the lateral compartment with this lateral closing wedge osteotomy. Similar work done by Dugdale and Noyes suggested we should be aiming somewhere between 62 and 60% of the tibial plateau in order to be able to achieve satisfactory outcomes. So let's take a point. In my practice, we use 55% of the plateau. And you can see this diagram demonstrates this is a varus knee with the mechanical axis going through the medial plateau. Now let's go ahead and do a biplane osteotomy and say we are aiming for 55%. This looks good, hinges intact, we've got a rather large opening, but we're creating a secondary deformity by having a very large MPTA. And now that we've been doing more work on this, we know this is not satisfactory. So we can't do this talk without talking about double level osteotomies. We know that double level osteotomies work very well and in fact are important to consider when you have an oblique joint line obliquity. Let's just take this for an example. On the left side, you can see this is varus, drawing a mechanical axis going from the femoral head to the center of the ankle. And now we've drawn a red line demonstrating where we want our weight-bearing axis to end up. And if we simulate this, this requires a 19-degree correction. But the MPTA, importantly, goes to 100 degrees. So if we were to do this, our joint line obliquity would be significantly increased, and this would be a very unsatisfactory outcome. So this patient would be more suitable for a double level osteotomy. This is another example. This is on the right side with varus OA. You can see grade 4 disease on the medial compartment. Mechanical axis is now missing the medial compartment altogether. So if we simulate a lateral distal femoral closing wedge osteotomy, we partially correct the mechanical axis to a more acceptable position. And now this is far more acceptable to do a high tibial osteotomy without creating a secondary deformity. And this is exactly what we did. This is utilizing the new clip system. It's not the plates, it's about the level of deformity, doing the correction in the correct place without causing a secondary deformity. So now this is coming towards the end of my talk. This is to show you how easy it is to perform the analysis. We mark out the center of the hip and the tip of the trochanter. We mark out the femoral condyles. We do this initially very roughly, and then we go back to do this more accurately. So here we are zooming in. We move the markers, so we do the bony landmarks is what we defined earlier as to where the distal femoral condyles finish and where the proximal tibial plateau starts. And as you can see on the top left-hand corner, you can see the MPTA and the LDFA are both abnormal. So this means there's a deformity both in the femur and the tibia. The trauma CAD has now marked out our anatomical and mechanical axis, and we're now going to put our marks as to where we would normally do our osteotomies. This is where our hinge point typically is on the medial side and the distal femur, and this is where we start our saw cut. Once this is marked out, we can then get rid of the cora lines and define a second cora. Here we are. So now we're going to define our hinge point onto the tibia. So you can see that the hinge point is at the top of the fibular head. If you have a more proximal fibula, you may need to adjust the hinge point, but this is the ideal position for your tibial osteotomy. Now, you can see in the top left, the JLCA, the joint line congruency angle, is 5 degrees. So there is a degree of soft tissue laxity in this patient. So we need to make sure we correct this first prior to doing any bony correction. Otherwise, we will overestimate the degree of osteotomy correction that we need to do. So it's a very simple thing. We're going to simulate the tibial osteotomy first, because this is what traditionally would have happened. A varus knee, let's do a high tibial osteotomy and see what happens. You can see the MPTA is massively increased to 98 degrees. And it's a rather large correction of 17.1 millimeters, which of course is doable, not an issue, but you are ending up with an MPTA which is abnormal. So the order of the sequence of events is to first correct the joint line congruency angle to an acceptable level. In this case, we aim for 2 degrees. We then move on to do the distal femoral osteotomy. Now, in our experience, it's to do a distal femoral osteotomy, you really should be doing it at doing a 5 to 6 millimeter minimum correction for a satisfactory procedure. And in this case, we have gone for 5.4 millimeters, and it's given an LDFA of 86 degrees, which is perfectly within normal limits. And now we can safely carry out a simulation in the to simulate a high tibial osteotomy, which will take us to an MPTA, which is 89 degrees, and an osteotomy correction of 7.8 millimeters, which in real terms would be 9 millimeters, as we will be accounting for our saw blade thickness. And you can see that our mechanical axis is now on this radiograph going through the lateral tibial spine. But if we were to measure this, it would typically be at 55% of the tibial plateau width. So we highly recommend using electronic planning, and this has changed the way that we do things. TraumaCAD in particular gives you lots of different options. This is the system that we use. It links to your PACS, and the kind of world we are living in at the moment is very important to consider medical legal aspects to demonstrate that you have thought through your osteotomy, you've taken everything into consideration, and you've executed it on a plan that is precise. So that's the end of my talk. Many thanks once again, IPS, Bhushan, and the Indian Arthroscopic Society for having me today. It'd be great to connect with you. These are our details. We always welcome people to come and visit us from abroad. It's not unusual for us to host surgeons from around the globe to come and see us do some operations. And thank you once again.
Thank you, Rags. I think is Bhushan there?
Yeah. That was a really good talk, Rags. How can I just ask a quick question?
Of course.
So just wanted to know something which is always on back of my mind. If the JCLA, the joint line convergence angle, is significantly high, how do you decide how much to subtract for your soft tissue correction? And do you actually do that every time, or you just decide on table?
Yeah, so there's a formula which Kristian and Philip Lebenhofer, they wrote a paper on, in fact, and it's simply the formula is take JLCA -2 divide by 2, and if it's increased, but that's something that we take into account by doing a correction in our planning. But it's also important to then make sure that the plan that you've made up is also assessed on table also. So it's combined, and that's done by testing the ligament tension post-operatively, stressing it, and seeing that you haven't overcorrected it. We don't. Gone are the days where we still do have alignment rods, and this is something that we still use in theatre, just to double check everything. But this is something that Matthieu, Kristian, myself, and Adrian are actually writing a paper on at the moment, and hopefully that will be in publication soon.
Right, can I just jump in? Kristian, I'm not going to put you on the spot, but it's such an important point. At some point, could you just show those 3 slides to go through how you average it out? Because it's something that everyone asks is, how do I account for the joint line convergence? You've got those 3 great slides where you show, actually, if you take a standard deviation around the midpoint, you can halve your effective mismatch in terms of if you get it wrong, you're only going to be wrong by a very small amount. So maybe, Rags, because it's such an important thing, Kristian, could you show a couple of slides later on that? I think it's a brilliant question, Bhushan.
Okay, so IPS, any more questions?
No, I think everybody's asking about the JCLA actually.
Yeah, so that was the query I had as well. Just one more question
now.
I wanted
Possibly,
to ask,
why don't we step back to Rags? Rags, if you open
do that. Shall I put that up? Yeah.
So open the slides again. I mean, there seems to be some controversy around, so it makes sense to open it up again if you share your screen.
Yeah.
Just one moment, guys.
So while Rags is searching for it,
I've got
Kristian and Adrian. Yeah. Oh, you are okay. Open it.
So Perfect. Yeah. If we take the next slides now.
So I initially took these. Yeah. So here are the slides. Kristian, do you want to talk about it?
Well, you can as well, obviously.
Yeah,
so I mean,
go on.
Yeah, go ahead. Go ahead.
So this is a standard deviation of the different JLCAs that you can range. And so if you can go far to the left, you under anticipate. And if you go too far to the right, you can over anticipate. And we're trying to limit the amount of error that we're creating with our joint line congruency angle and staying within an acceptable limit. And this is referred to here as the likely corridor. And the formula I think Bhushan was referring to is what we use here in the middle of the graph, and that will allow you to significantly reduce the error related to your joint line congruency angle. Kristian, did you want to add anything to that?
No, it's just maybe to make sure the thing from the very start. If you go like 3 or 2 slides back, where you started beautifully from with this 8-degree, yeah, right there. So we have a joint line. Let's take a simple example because some things are easier to be explained on an example. So this shows a joint line convergence angle of 8, which is quite a lot, obviously. So we have like maybe a little double or triple varus, so some stress on the lateral side and some constraint on the medial. Now the question is to what kind of extent will that constraint on the medial and the stress on the lateral side release after high tibial osteotomy? Well, the simple answer is we don't know in the individual case, and we cannot tell. What we can do is what Rags already pointed out. We could do a stress X-ray, or we can perform some Rosenberg views and so on and so on. And that would give us at least some information, but not the complete direct figure. So still at the end, I guess preoperative planning, proper radiologic assessment, probably with stress X-rays and intraoperative control, plus a good planning, at the end results in the perfect surgery. But anyhow, from here on, JLCA 8 degrees, which is quite a lot, we want to transfer that basically to a normal value, or we can expect it to open. And when it opens, it may open to a joint line convergence angle of 2 degrees, what is normal. So, and all the potential all potential corrections that may arise during our surgery now play within this 8-degree and 2-degree margin, because it won't do us the favor to cling to the other side and open up intensely on the medial side and transfer it to the opposite, obviously. So the hypothesis is now when you correct it, then it all reacts within this margin of 6 degrees from 8 till 2. And as 2 is the normal figure, we say, well, if that's the margin, why don't we just draw it as a bell curve with a potential likelihood that is rather in the middle, so that it does not react at all and remains at 8 degrees. The likelihood is quite small, and that it reacts completely and ends up at 2 degrees. Well, this likelihood is also quite small, but it's quite likely that it ends up in the middle. And this is described statistically by a bell curve. And so therefore we have this range of 6 degrees with a corridor in the middle of these 3 degrees divided by the standard deviation to each side. And if you want to put that into math and you want an equation for that, then you just take the joint line convergence angle, which is 8 degrees minus 2, because that defies the range, because you come to normal means if you end up at 2. So this is the 6 degrees. And if you want to have the middle of these 6 degrees, well, the middle is always divided by 2. So this is a correction of 3 degrees that you need to apply for a joint line convergence angle of 8 degrees. That would be my philosophy on that.
Thanks, Kristian.
Of course, you can. One more maybe. You can make it now more precise. If you say you apply 3 degrees in order not to over or under anticipate, now you can check your stress X-rays and say, well, it opens quite drastically. So this is almost going to 2. Well, then you apply a little more. And if you say, well, this is completely contracted, it does not react at all, and it will remain rather at 8, then you go to somewhere between 5 and 8, which is then these 6 degrees, and you then rather apply a 2-degree change. So that would be the adaptation of this formula based on radiological findings. Okay.
Fantastic. Good.
Does that mean we need a stress X-ray to actually see for the convergence angle?
Well, let's say it gives you an extra information. It does not necessarily mean that you cannot perform an osteotomy without a stress X-ray. But I mean, if you can gather some extra information and that all influences your overall decision making, and any further information makes it simpler for you to come to a perfect result, why don't you do that? I mean, this is what any policeman and investigation does. I mean, you take a look at it from different aspects. So we're a little bit detectives here, searching for the right thing.
Yeah, we saw the immense capacity of a trauma CAD to actually do a planning. We would actually love to see in future presentations how exactly this planning is executed on table to the perfection which trauma CAD does it. To see on a computer is very, very good, but see how actually you do everything on table and just cross check.
Yeah, can I just jump in there?
Yeah.
IPS, can I
Yes,
jump
sir.
in there? We used to, because that's a really important point you just made again. We used to be very nervous about digital planning and then relying on that digital plan for our definitive go-to in surgery. And let's double check. And we did some, in fact, Matt, I think, did the publication on this with David Elson. And we looked at, so jump in, Matt, anytime. We looked at the accuracy of using rods, using pre-op planning and all the different mechanisms, and actually came to the conclusion that we were accurate enough with our pre-op planning that we just go with that. For Matthieu, it's very easy. There's no check. He just goes with his PSI. And with us using trauma CAD or something like that, we don't check. We don't use the rods in theatre unless we're doing something complex. So we do the plan, we execute the plan just according to how we've done the pre-op planning, which is, as I say, easier for Matthieu because he's worked it all out with his fancy guides. Matt, have you got anything to say on that?
Yeah, I'll just jump in
Both of
quickly. So basically, Ronald published a paper comparing the use of different planning softwares, and so saw that there was great intra-observer reliability. And similarly, we just took the idea of PACS annotated player planning. So myself and two colleagues, David Elson was my fellow at the time, and another guy who didn't know anything about planning. He was taken through the process of how to plan using the Miniaci, a modified Miniaci technique. And we compared our 3 sets of results over 20 patients, and they were remarkably close. So it's just to say that it's actually a very reproducible technique to use this planning formula, and just turning angles into gaps is what it's all about, and measuring gaps and reproducing that in the surgery, in the operation itself. I think that's something you really have to see with your eyes. I think that's an experience, and that's why you need to go and visit and see masters at work.
Yep.
Okay.
Yeah. So,
should we go to our next presentation now?
Yeah, I think Bhushan, yes.
Yeah. So Kristian, let's start.
Perfect. So thanks for the introduction, and thanks for the invitation. I had the chance already to speak a little, so I jumped directly into that. I was asked to talk and speak a little bit about surgical technique and show some videos, because that's mostly quite instructive when you see what others are doing. So, but anyhow, I cannot avoid to get you through some well, scientific stuff. I don't know why this starts all automatically. Well, looking now at the side of deformity, well, we found in our own series in Hannover back in 2014, the practice where I worked, that 20% of our osteotomies that we had to perform after proper analysis of the malalignment were originated in the femur. And that was quite a shock for us and surprising, as we operated 99% of our patients at the tibia, meaning we operated 20 or 19% at least at the wrong bone. So we thought it makes sense to incorporate this femur a little more often, and therefore, yeah, it became more and more a part of our practice, because as you have seen before, and as Rex pointed out, you may have just corrected the Mikulits line for the sake of the load bearing, but in fact, you completely created a secondary deformity at the tibia potentially. And to avoid that, you need to put the femur into your armamentarium, because otherwise you will end up with a completely disturbed MPTA postoperatively, and that leads to early deterioration. So now, taking the femur into account, and well, you decide that this is part of your normally or your normal working plan. It becomes one of your workhorses. We were faced with the fact that we weren't half experienced with the femur than with the tibia. And we had our failures at the very start, because the femur is quite a brittle bone. It doesn't allow lots of errors, because there is a smaller safety margin. There is not such an anatomic structure like the proximal tib fib with strong fibers helping you out in terms of hinge protection. So you need to be very precise. And we started in a scenario where we had really reliable plates and so on and so on. So overall, the failures were quite, failure rate was quite huge. And then we tried to do open wedges at the lateral side, and this all resulted in lengthening, which was a problem with the IT bend and so on and so on. So overall, quite frustrating. So it makes really way more sense for the femoral side to go for and look for some biomechanic stable fixations. Well, the gold standard back then was the blade plate. The only problem was whoever put in such a plate in a bone possibly had the experience that even if the hinge was stable up till the moment of insertion, when you tap it in, it breaks. So apart from that, you need long incisions, as you cannot really go for MIPO plating, minimal invasive plate osteosynthesis with such an angled plate. So overall, it made more sense to apply the ideas of the angle stable plate fixator to the distal femur, but then not from the lateral, but from the medial side. Now, coming from these traditional approaches and these osteotomies, we rather cut due to those blade plates in horizontal shapes. And that doesn't make a lot of sense, as Stahilin pointed out, because when you cut it in a horizontal fashion and close the osteotomy, and you want to apply for a closing wedge, as I've just explained, and the reasons were given, well, when you close these horizontal cuts, then you have a step off at the closing cortex. And what we want to have is a complete fit. So we want no offset, and we want an isosceles triangle to gain full cortical support, because that leads directly to higher and significantly higher stability. So therefore, the change of the shape of the osteotomy was changed. So you need to find first at hand the hinge point, as you see here, directly on top of the contralateral condyle. And then you draw a line to the starting cortex. And this line needs to be tangential to the starting cortex. So just the midline that creates rectangular triangles to your starting cortex is perfect to be the center of your osteotomy. It shall not be too high and not too low. And for the femur, we applied the same rules as for the tibia with the biplanar, because there is other advantages. You can remain lower with your overall osteotomy. That does mean that you remain in safe bone rather in the metaphyseal area, and not so much in the diaphysis of the femur. Generates quicker healing, and you don't disturb, as you can see here directly, you don't disturb the patellofemoral joint. So you just take the posterior 3/4 or 2/3 of the femur, and all the rest in the anterior part is for the ascending osteotomy. So this is how to find your osteotomy at the femoral side. And this is such a scheme of the idea from Alex Staubli, in fact, to transfer the same ideas from the biplanar HTO to the DFO and make it a biplanar surgery. Then you just take out the posterior wedge and close the osteotomy. So let me take you through the steps, because this is a schematic lecture on that. So you just perform your incision above the region of interest, rather from the medial or lateral side. Go through the fascia and find the posterior aspect of the intermuscular septum. This is where you release it, gain access to the posterior part of the femur, apply these K-wires and perform your cut. And then by distal compression during the surgery and intraoperative control, as we were pointing out, you can perform the surgery. Now I get you through a video of such a surgery. You see, we rather perform little incisions at the region of interest, mark our anatomical landmarks beforehand, and then we incise the fascia at the medial side, and at the lateral side, it would rather be a J curved incision that releases the IT bend. So, but let's take the normal scenario of the medial side. You make a blunt dissection and find some 3 little vessels, the 3 sisters on the medial side. And this is typically at the area of the osteotomy. Then you go to the back of the femur and free everything. And now this is very important because you can really detach all the structures from the back of the femur and win space, lots of space for a safe saw cut. And possibly, if you want, you can put in a Hohmann retractor or any other device that saves you from cutting neurovascular structures. I personally use my finger, and because I rather cut into my finger than into the patient's popliteal artery, but I have a special saw for that, which is the Stryker precision saw, and there not the whole saw blade moves, but it's just the tip of it, and therefore protects you quite nicely. So I just take 2 K-wires, as you see here, and identify the orientation in terms of anteroposterior orientation for the sagittal plane by making an initial cut at the cortex under fluoroscopic control. So you just cut the cortex slightly, and once that's done, you cannot incline your saw blade anymore to either direction. So you then take it out, go to the other K-wire, and do repetitively the same. So under fluoroscopic control, now you can go quite far to the lateral side. And this is a very important point now. In each and every case, we shoot a golden K-wire, a hinge wire, to stabilize the osteotomy before the definitive ascending cut is performed. So now this is the marking of the ascending osteotomy. This is now the ascending osteotomy itself. You should start distally, go upwards where you exit the femur, and then you go low again at the contralateral side. So like in a meandric fashion, you kind of sneak around the cortex to get it all done in a perfect shape. And once it's cut completely, you remove the wedge in the posterior 3/4 of the femur. Now, this can be best achieved under slight valgus in this case. So, and now I put in my saw blade into this gap that you've just created to repetitively go in and out under protection of the remaining K-wire and the hinge wire. So I just do that to sweep out all the remnants that are potentially inside and act like a seesaw, like a hinge barrier that potentially may break your hinge over. So then after closure, you just make a fluoroscopic control, put in the plate, slide it in a meepo fashion, just as I've shown you. Well, and then it's a standard procedure of putting in screws and plate. So there is no big secret about that. There is some little tips and tricks, obviously, that I can share. For example, this passport cannula without any valves that we put inside. We cut out the valves because we want to have access. And then we just feel where to place the K-wire for the shaft fixation. And once that's saved, you make a lateral control, and then you can toggle around the distal and proximal fixation in order to have a proper fit. You see that the K-wires alone are stable enough to hold everything in place, but you need to be careful. It's a brittle construct in this moment, and then you just put in the plate. So I guess we can accelerate that. And the same now exists for the high tibial osteotomy. So once again, positioning of the patient in supine position. We personally lower the contralateral leg and put in a roll for the foot and a side post to have the option to put it in a flexed position. Then under fluoroscopic control, once again, you shoot the K-wire from the medial aspect. I will show you in a soft tissue video now in a couple of minutes. How you do that, where to aim? Well, we've spoken about that. There is this safe zone concept where to put the hinge, because we always think that the proximal tip fib works like a pillar, like a hand that holds everything safe in place. And you want to avoid a Takeuchi 3 or 2 fracture. The 3s go into the joint, the 2 go low, and they are potentially unstable. Whereas a safe Takeuchi 1 fracture is rather not a complication, but normal. If you look at CT scans, you just need to have it compressed. And how to compress, I share another one with you in a couple of seconds. So a good idea is to imagine the fibular head as a head, and then you shoot the head from the head in order to have the right point for the tibial hinge. So now you shoot K-wires, either 2 or 1, it does not really matter. You just need to know about the orientation of the saw blade, once again in a biplanar fashion. And you then, after performing the cut, I will show you how you do that. You put in some chisels to gradually spread it. Don't put them in all at the same depth because you don't want to distract the hinge. You want to spread it gradually over the whole length of the osteotomy. And then you have an osteotomy spreader like this one, a laminar spreader that helps you to fine tune and open your osteotomy the way you want it, control it, and fix it. So now, thanks for Adrian. He came up with this slide, a very, very simple one, but a smart one because it raises questions. And these questions are what to do with the MCL, how to prevent neurovascular injury, and what to do to protect your hinge. And these are 3 main concerns with every HTO surgeon, or for every HTO surgeon. So, and we try to work on these tricky questions and give you some tools in your hand in order to solve your problems and to answer your questions here, because that would really drastically help to promote osteotomy further and bring this back its place that it deserves, actually. So looking now at the posteromedial aspect of the tibia and the popliteus muscle and the popliteal artery, you see that there is an anatomic variant, and this is this high-riding artery that may lie directly underneath the popliteus muscle, touching the periosteum. And it's really hard to avoid to cut that during a high tibial osteotomy, and that really can bleed massively. So you can open the osteotomy quite far in order to coagulate this little bleeding branch during the surgery, but it's hassle-some, and it's really shocking when you do this surgery and it bleeds like hell, and this really bleeds like radial artery. So this is massive. It's therefore by far better to avoid to cut it, and this is what you can do, and we developed a technique for that, to rather access your tibia from the back behind the MCL and not anterior to the MCL, to insert a retractor. We designed one specifically with new clip for that purpose. So this is a tubular retractor with a little tube for a K-wire, a nitinol wire that you may shoot in order to fix it at the back of the tibia. You shoot it through the handle of it, and then you have it fixed in place, so you cannot lose your position anymore, and it gives you really a very, very safe saw cut in order to execute your HTO. Now, I want to show you how to do that. Well, we make a minimally invasive incision rather in the mid part of the medial aspect, from the tibial tubercle to the posteromedial corner. You take away the pars tendons to the distal side with this retractor, as you see. And once you've done that, you get access to the medial collateral ligament. And usually we kind of like in a sleeve release, cut it all the way down or sleeved it all the way down. But now, as you see, we go to the very posteromedial corner of the tibia. release everything with this periosteal elevator, and then you can stick your finger inside and feel the whole posterior aspect of the tibia. And then you just put in a tubular retractor, in this case, another one that we used back then. Now we designed this, our own one, which is not in this video yet. And in order to really find proof that there is no soft tissue interfering, you scratch at the posterior aspect of the tibia to prove that you're at bony surfaces. Then you rotate it 180 degrees and scratch at the metal of the retractor. And only then you start to make a definitive release of the medial collateral ligament in order not to over constrain everything by the aperture of the osteotomy. And then you revert that to the back, put in a small Hohmann retractor. We use one out of the foot and ankle set. Then you get access to the complete medial aspect of the tibia. Well, now you shoot your K-wire and so on. And as I've shown you, I just shoot one under fluoroscopic control. I do this in extended position, and we also now do the cut in extended position. Well, once this is done, you can see it on the X-ray. It's completely in line with the retractor that is inserted in order to protect your saw cut. You can then check the depth of the osteotomy. You shoot the K-wire as long as the bony streak is inside, and then you check the length, subtracted by some 5 till 10 millimeters, because you don't want to cut the whole of the tibia. And then you perform sneaking along this K-wire. You can see that you can tilt the saw blade under fluoroscopic control till you find the ideal alignment. And then you just enter it, and you don't need a second K-wire, as the cortex defies the orientation of the saw blade in the sagittal plane. So then you can cut very safely the posterior cortex, and you don't have to be in fear anymore that you cut posterior neurovascular structures. You can control it on the fluoro, and you see we are almost there. So now, it's putting in a plate. We today use the nuclear plates. They are smaller and of same durability, really perfect plates for a high tibial and distal femoral osteotomy. They are designed to fit anatomically. So this is really a great plate construct, which is very easy to be inserted. In fact, I just use one incision now because I used to have 2 incisions to lock the shaft. Screws. I don't have to do that anymore, as the plate now is tinier, and it was somewhat always a problem with a Tomofix plate, which is a perfect plate, but anyhow a little bulky. And the smaller the patients are, the less it's accepted to have a bulky plate under the skin. So there is quite a high percentage of implant removal. So that's the plate we put in. Works perfectly in our hands, and we are really pleased with that. So now a last one, maybe, because that's very important. This is a great concept that actually was brought up by Nuclip, and more precisely by the CEO of the company, Greg Lachey, whom you see here on the left, along with Seb Parat and Matthieu Olivier, who will speak in a couple of seconds. And well, they put out some science on that and have proven that the stability of such a K-wire, hinge wire concept is absolutely insane. It's 500% stronger than a hinge without a K-wire. And well, as we thought it makes sense to put in this K-wire, we thought it makes even more sense to drive a screw over this K-wire, which has a differential pitch to enforce your hinge after the surgery, and not just take out the K-wire and use it as an intraoperative protection. We now use that as a definitive protection for during and after the surgery, and that enables us to take our patients and bring them up the next day after the surgery. So this is a patient after distal femoral osteotomy, 15 hours after the surgery. So that's after a distal femoral osteotomy, and the same here now for a tibial osteotomy, the same concept. We don't use it through a PSI, which is obviously possible and ideal if you start with such a surgery. It makes sense to do that. We try to do this now as we are more experienced in a freehand approach. And this is such a patient that we operated in our London practice. Same for him, 15 hours after high tibial osteotomy. This patient was able to walk. There was a closing wedge, as you can see. He was able to walk, which is in closing wedge is obviously easier anyhow, but able to walk at day 1. So this is how we do our osteotomies for the tibia and the femur today. And there were really great novelties and advancements over the last couple of years. And there is still way more to come. It's really an open field right now at the moment as osteotomies start to evolve more interest and are really gathering interest all over the world. We try to incorporate all this into our London practice and try to be ahead of the game and show people from all over the world how we imagine osteotomies should be or can be performed today. We invite you to visit us there and take a look what we are doing. This is kind of open house policy because we want to spread osteotomy to the world. So thank you for your attention, and yeah, I'm open there and for questions, and then otherwise I leave for Matthieu. Olivier, thanks a lot.
Thank you, Kristian. I think a couple of questions coming in. So, Bhushan, I can just put in 2 questions which have come on the chat. So yeah, Kristian, so first question is, there are companies which are coming with some hinge pins and zigs. So would you actually advocate people to use those hinge pins and zigs to aim the osteotomy well, or it's more of a problem?
Yeah, this is different aspects. I would say, well, the hinge pins itself, this is a concept which is rather brought up by Nuclip. So that's a great concept. Actually, we use that on a routine base now in each and every case. And we even go further and put a screw across. So that's the next thing. And obviously there are, this is also by other companies that try to bring this in an automated approach, like with the PSI, and we will hear about that in a second, in a PSI approach to facilitate the insertion of such a K-wire. Well, do you have to do that? Obviously not. I did this for like 10, 15 years without any hinge pin, but you know, things go on. And obviously, you can, I don't know, you can travel from city to city with a horse. Today, I use a train or a car. I mean, you know, things go on and develop. And I think it makes sense to incorporate that into your practice, because some things just make you smarter and better.
Okay. Another point which is there. So if somehow that hinge is broken while doing an osteotomy, would the compression screw, which you said would is a bailout option?
Yeah, that's a good question, actually, because we had the same, and obviously it's a big concern. This is why Adrian came up with this beautiful slide, how to protect the hinge. Well, it is possible. It is possible to protect your hinge with that, and it's possible to protect it after the surgery. But it's also possible to fix a broken hinge with that. And this is really a very, very big advantage, because we early on we really opened the contralateral side and tried to put a plate there. Now you can now in a percutaneous way try to fix your osteotomy and get it stable. I don't say that this works in 100% of the cases, obviously not. I mean, this is fracture depending, and you need to fix a fracture accordingly. And in some fractures, it just works. So I would not use that for an intra-articular fracture and Takeuchi 3, and I would not use that for a low fracture Takeuchi 2. But you can absolutely try to give it a go for a Takeuchi 1 fracture, which in my hands is not really a complication, but has to be considered as some kind of a normality. At least on a microscopic base, you will find that in each and every case.
And Kristian, the plate which you showed, does it allow compression at the hinge as well?
Yeah, well, there is not such a concept like a golden screw, if you take the Arthrex term for that, which was never a golden screw from the Synthes wording. It was a compression screw, so you just use a leg screw. Obviously, you can use a leg screw with any plate, even if there is not such a hole which is dedicated for that, like a combi hole, because the combi hole idea was back then commercialized and patented by Synthes, which is now open and not protected anymore. So any other company could implement that into their products. But anyhow,
Kristian, can I just jump in? I think I mean it's a really, really important point again. I guess that we've had this great idea from Tomofix with this golden screw, and we've all seen it compressing nicely. It gives us a lot of confidence, and every patient has a Takeuchi 2 microscopically, and we can achieve even a reduction with that screw. It's great. And we said to Nuclip, with your plate, you need to come up with solutions. So first of all, they did everything they could to minimize a hinge fracture. And I think the work that Matthieu Separa and that Gregoire initiated with the hinge wire is a real step forward. And then more recently, soon to come on the market, I think devices that we've seen and been working on, actually it's not our idea, it's a Nuclip concept for one of their engineers, is a direct compression device that will allow the plate to achieve exactly the same. And I think that, along with lots of other little goodies that Kristian, myself, Matthieu have all been working on, are all going to be rolling out, you know, as the lockdown unfolds, and we can start to show these nice new goodies to you. I mean, it's a fantastic thing, like a rapid plate applicator that Kristian's developed, where the plate goes on and then a ghost goes over the top. You drill all the holes, it's temporarily fixed. You take the ghost off and you put all of your screws in, drilled them, fixed, you know, these kind of things. So I think it's all coming, and I think the direct compression device that you'll see from Nuclip will be more than adequate to satisfy everyone. Careful surgery is key, basically, with osteotomy,
absolutely.
of course.
And what about you said you put a protection K-wire, and then finally you put a screw, replace that K-wire. So is that screw a cannulated screw over the K-wire, or you take out the
so
wire?
we just took the old Accutrack concepts of a differential thread on the screw, and Matthieu, our lead academic, Professor Matthieu, is going to be doing a biomechanical study for us. Should have happened before, but the lockdown stopped, so we can mess around and see what's the best screw, what length, how far should we put it in, come up with easy ways to deliver it. All we're doing at the moment is just freehanding a differential screw. The one we're using is a large Accutrack. I mean, I think it's a 50 or something like that. And we've just done it on a few cases. Really, now we need to do some science and actually show there's an advantage to it in the lab and then clinically.
Absolutely. Yeah, Bhushan.
Okay, so it's a fantastic technique of putting a hinge protection that we all incorporated in our practice now. That seems to be working quite well. So there's one question, whether the hinge screw, whether it needs to be perpendicular to the plate or needs to be in any other plane as such. So Adrian and Kristian, what's the direction of the hinge screw? Is it perpendicular to your osteotomy?
No, you can't achieve that, Bhushan. So what we're trying to do is come in on the edge of the tibia from the joint line, and then come down, incorporating the hinge area. Maybe two screws is going to be, one at the back and one at the front is going to be very effective. We don't know. For the femur, which we think it will play a bigger role, we're coming from the joint line and we're shooting up, and we're just getting it in the middle of the bone and we're crossing the hinge.
Kristian, a lot of Indian surgeons actually do a uniplanar femoral osteotomy, and this biplanar was quite interesting. So if you can just maybe by a line diagram show, because this is what people are asking. How exactly the second plane, is it perpendicular to the first plane? How exactly do you do a biplanar?
At the femoral side?
Yeah, at the femoral side. Tibial is always biplanar. We do it, but on the femoral side.
I will show you the slide again.
Yeah.
I will show you
just whilst you're finding that, Kristian, it's exactly the same concept, IPS, as the tibia.
Okay.
Actually, the femur is more rectangular, and it's 3/4, 1/4. So you're cutting from the back up 3/4. You're stopping 25%, and then you're shooting proximally, always proximally. That avoids the extensor mechanism, the trochlea, and it has a very, very big stabilizing effect. So you don't get this horrible rotation that you can get if you go all the way through the bone, and you get healing rapidly. Those are the main advantages as of a biplane.
There is a
So
question
here
here.
you
I
see,
think, and also you can protect the trochlea as well. So Adrian,
Yeah.
you can also protect the trochlea as well, and you can be metaphyseal. You can be very low.
Exactly. So you're low. You're avoiding the extensor mechanism. You're avoiding the trochlea. You're creating stability, and you've got a huge buttress of bone against which you've got stability, and also that will heal. But as Bhushan has just said, it allows you to get very low into that nice cancellous bone, the metaphyseal bone that will heal.
Yeah.
Sorry,
Kristian.
Kristian.
Can we see this? Yeah.
Yeah, no problem. I mean, you described basically everything which is presented here. So the whole concept has the idea to be quite low in the metaphyseal area. You take the posterior 3/4. If you take the lateral view now, the posterior 3/4 for this oblique osteotomy, and then you take the anterior quarter for this ascending osteotomy. That goes like that. It's like a windshield wiper describes the curve here. So, and the only idea now is to take the posterior aspect of the femoral cut for the oblique osteotomy, and the anterior quarter or 1/3 for the ascending. And well, that's it. If you want to look for well, how to go there? Yeah. If you take a look at these images, basically the normal osteotomy early on was a little bit higher, because you try to, or you're always in risk to get into that patellofemoral joint here. So a little bit higher, and you've just cut through. But the problem is with a monoplanar distal femoral osteotomy, it's quite round at this area. And when whoever lost the hinge in that situation knows that it's somewhat very difficult, and it might end up in a disaster to get it fixed in a proper orientation and rotation. So you end up quite easily with a malrotated limb at this procedure if you lose your hinge. So in fact, there is not only the advantage of this biplanar to give a higher surface, higher bony surface that accelerates healing, the option to go lower with your overall osteotomy to rather come into metaphyseal bone, but also to give you a good orientation on how to get it reduced when it all falls apart. I mean, obviously, the biplanar gives you an idea anyhow, whether you have a rotational profile problem or not. But when you are aware that you have such a problem, when the hinge breaks, then this one helps you out, because that is very easy to be reduced. And if you don't have a biplanar, it's not at all. So this is why I changed my practice completely to this biplanar. There is like only advantages and no disadvantages. It does not really make sense to do it in a different way.
Question to all. What is your take about Egletti's sagittal osteotomy? Is anybody of you still doing in adults the Egletti's V osteotomy? It's supposed to be quite stable, and so.
What kind of an osteotomy? I did not get that.
It's a sagittal V osteotomy. It's on the sagittal plane, popularized by Egletti. So that's a question which came to me.
This is nothing which basically not part of our practice.
Not a part of your practice. That's okay.
Yeah. So the only time we do a V is for frontal plane correction, for sagittal plane correction, when we're doing slope changing. Then of course we do, from the front we make a V. I don't know if that's what you mean.
No, it's in the sagittal plane. So you actually go from the medial side, but instead of cutting it like that, you actually cut it like that. Remove a part of the cortex, and then you can actually put the bone into the bone, something like that.
Not for me. I'm not familiar with that.
So that's okay. That's it. Perfect. Bhushan, any more questions? Because these were which came to the chat to me.
IPS, can I ask one question?
Yeah, sure, please.
Yeah. My question to Adrian and Kristian.
Yeah, go ahead, Sandeep.
Yeah. I think the device, the wonderful device which Adrian showed, that to retract keep the posterior aspect of the tibia. I think I understood that it is done in the flexion of the knee around 90 degrees when you insert the device. So I think when you do osteotomy, we do the extension.
Right.
My question is of the bulkiness of that device. Does it stretches the soft tissues too much in the posterior capsule or a neurovascular structure? Does it harm
This-
that? If that suppose surgery time prolongs, will it be a harm?
It's a very good question, because it's really, that was one of the most complex things to get the right order and the sequence of everything. So you are absolutely right. To put in a retractor posterior to the popliteus muscle, you better start off in flexion, because everything is relaxed. Now, if you have something then inside and go to extension, does this cause any harm to the anatomic structures that you have just released? Well, it does not at all. It would do harm to the medial collateral, but what we change overall is the approach to the tibia. So we go onto the tibia in the back of the medial collateral, so you don't change anything. And it's very, very good, this question, because once you ever start with this procedure and do it the way we do it right now, why don't you just initially take your finger and pretend that your finger is the retractor that we insert and go from flexion to extension. And then you feel yourself what it does to the soft tissues. And in fact,
yeah, great.
There is no pressure at all.
Adrian muted.
Adrian, you're muted.
There you
Yes.
go. Got it. The way we used to approach the MCL, as you saw in the video, was always to sort of force it down, even if it was released, and then come under at the wrong trajectory. And Kristian came up with this great idea where leave the MCL alone, come to the back of the tibia at the right angle, make an incision, scratch the back of the popliteus off. You can put at least a finger, if not 2 fingers in, so it easily accommodates that guide. Then you know everything is below you and you're on the bone, there's no aberrant branch, and you can cut safely. The next step will be to link that guide that we've developed to the saw, so the two are physically linked. And then no one can, hopefully it makes it even safer. But those would be the comments. I don't think it causes any soft tissue disruption posteriorly, because you need it to be loose enough to get your finger in so that you can feel the bone and that you've cleared everything. And I think that technique allows it, and allows you then to manage the MCL as a secondary procedure.
So I think, Bhushan, we can go to the next presentation if there are no more questions here. Yeah.
Okay.
Yeah, Matt.
I think it's mine, huh?
Yeah, we can see you.
Okay, great. Thanks first for the huge opportunity to be with you guys today. I'm very happy to spend this next, let's say, 10 to 15 minutes explaining you how we get into PSI regarding osteotomy procedure. As always, I will start with some acknowledgement, and I will say that most of the work and the publications and the job that we'll see in the next minutes are highly depending on those co-authors. Chris, Rags, and Adrian are now close friends, and we are working together to try to improve the knowledge around osteotomy. Matt is an awesome president of the SK Osteotomy Committee that will also help us to provide new things, new tools, and new ideas around. Seb was my mentor in Marseille. He's now in Abu Dhabi, but he's still influencing me every day. And Chris is my fellow, actually, will be one of my partner. And you will see that most of the publication that will appear in the next slides are highly us to provide new things, new tools, and new ideas around. Seb was my mentor in Marseille. He's now in Abu Dhabi, but he's still influencing me every day. And Chris is my fellow, actually, will be one of my partner. And you will see that most of the publication that will appear in the next slides are highly us to new things, new tools, and ideas around.
Somebody is on YouTube.
Somebody is on YouTube, huh?
Yep.
Yeah. Okay, it's better
think
now. Sorry.
Fair enough.
Yeah, I think someone has got the YouTube on, huh?
Yep.
No, it's done. Okay, so let's move anyway. You still see my screen?
Yeah, we
Everything is
see
okay?
your screen. Yep.
Okay, great. So I got, of course, some disclosure because this PSI concept was designed with Nuclip Technologies. I've done my PhD on that, and lucky me, they help us designing this tool, and they're still helping us for new things around osteotomy. So let's start with these simple cases. This is a 24-year-old male with a medial knee pain, bothered in daily living. He asked me to solve this, and I say, okay, let's go for an osteotomy. So I do my Miniaci planning. You can see here that he got an 81 MPTA, 89 LDFA. So let's say it's an easy game. Everybody wants to shoot the tibia and to correct this abnormal angle. This is my 3D planning because I do a 3D osteotomy on him. So the PSI is supported by this CT scan analysis, and you can see that it's not so simple. Finally, the MPTA is 79. He got this huge slope with 76, and he also have a very high external torsion of the tibia with the 46 external torsion. So the idea was, if I'm intending to correct something on this tibia, probably I should correct the 3 planes. And Adrian and Rags were there this day, and we correct this guy with this PSI cutting guide. So more distal correction to do the derotation osteotomy, biplanar cut, and we correct both the slope and the frontal plane, plus the rotational issue on this tibia. And this is how the correction we perform. This is the final X-ray. So basically, you can see that more than PSI, the beginning of everything is 3D planning, and 3D planning will help you understand more what happened to the bone and what are really the deformity you need to assess. Knowing that, we all know that most of the success is based on planning. So for me, 30% of the job is done when the education is good, 20% is done when the planning is done. And if you're success having the good indication and the good planning, most of the surgery is already successful. You just need to adapt your hand. And as I'm not gifted like Kristian, we try to develop the system to help me getting better with my hands. And this is why the PSI come out. So this is the example of what should not be done. And I received those X-ray last week. You can see here that something is wrong, and probably the biggest part of the deformity is in the joint. And if you are not succeeding doing the good planning, you will end up with this kind of correction. 20 degree of MPTI is corrected. The MPTI at the end is like 110. The hinge is broken, of course. There is Takeshita fracture, and I think this poor guy will not go so well after a few weeks or months. And this is once again, of all the principle, if you need to understand something regarding PSI, it's only helping your hand. It will not helping you doing proper planning, proper indication, selecting which bone is supposed to be corrected. And even with this patient had a PSI in another center. And as you can see here, the correction was supposed to be 20 degree on the tibia, and this is what happened. But everything was wrong from the beginning to the end. And once again, it's only helping your ability to do a correct osteotomy and not your indication or your plan. So as said Donald Trump some weeks ago, we cannot let the cure be worse than the problem itself. So be aware that PSI is just a system to enhance your accuracy. It also enhances your ability to stop hinge fractures, and we already discussed that with the system we designed some years ago with the hinge K-wire that you will discover in the next slides. So basically, when we thought about PSIs, we were leaving the PSI for TKAs because we had several issues of implant positioning, and we thought that it might be a good option for osteotomies. And this is what we thought. We need to have something which is smart and easy for everybody, very accurate and safe, allow us to spare some time, allow us to do some additional procedures that usually we are stepping because we cannot do a single stage procedure because it's too complex, and probably do some crazy stuffs that we are actually not doing because we don't know how to do those corrections. Basically, the global concept is to correctly do your sewing plane. How to be sure that your sewing plane is in a good direction? Because if you move up and down on the, let's say on the frontal plane, you will change probably slightly, but significantly, your correction. It's even worse around the clock on the sagittal plane. If you move your sewing plane from some degree on the right or left side around the clock, you will see that the slope will change a lot during your correction. Is perpendicular to the mechanical axis of the tibia and parallel to the slope is mandatory to avoid any slope changing during osteotomy. And there is something which is very hard to assess intraoperatively. Last thing is the hinge position. It's exactly the same thing. If you move your hinge, you're also moving the way the upper tibia move around the distal. And you need to select very accurately where the hinge is placed to be able to correct intentionally or to keep the slope at the same position if you don't want to change it. And you can see on those images here, so the slope position should not be the same for a regular tibia, a very high or a very low slope. If you intentionally try to correct those guys with in the sagittal plane, the hinge position will not be the same. Otherwise, the opening or the closing you're intending to create will not work because the fixed point is not at a good position. So this, knowing that, you can understand that my PSI concept, our PSI concept, should take all those things into account, nicely position the sewing plane, nicely position my hinge, drive my sew to be completely accurately in a good direction, and finally be able to correct by itself. And it is maybe the first but the beautifulest idea of this PSI. Everything is integrated inside of the cutting guide. So how it works, sorry guys. How it works, it's very easy. So we start in 2015 at the end of the year. The global idea was to print down this little shape, which is CT scan based. The planification is in 3D. It needs 3 weeks to be printed by New Clip Society. It will give you 2 hinge. The first one you will discover that is the hinge key wire that will protect your hinge and fix the hinge position because you cannot cross this key wire with your sew. And the second one is just the sewing key wire, which is allow you to be stable and keep the sew tracked from the beginning to the end. Then you get holes, and those holes will be drilled through this PSI system. And when you position your blade on the tibia, it will not match. Because of course everything is here. The difference in between the screw position and the drill position, the hole you drill position, is the correction you intend to create in the 3D process. So everything is already prepared. The difference in between those map, the hole you create in the PSI and the hole in the plate, define the correction. This, I think this key wire is maybe the most interesting thing in the PSI system, knowing that, because it will stop the blade coming through it, and it will define a very exact spot, a round shaped spot of 1 centimeter square. And the sew can pass anteriorly, posteriorly, but this spot will be saved and your hinge will be fixed at the good position if you want to be stable in terms of sagittal correction or intentionally create a slope change. Is it really easy? So we published this paper last year in Kesta. I asked 3 of my fellows to start doing PSI osteotomy. In 3 years, they all do 21 cases with it. And what we discovered was that first, the timing was completely cut into two after 9 cases. Everybody was able to do osteotomy in less than 30 minutes with this system. Same thing for the number of X-ray, take it intraoperatively. Only 6 X-rays were took when we were doing maybe 25 to 30 X-rays some 10 cases before the beginning of PSIs. And all of them were very happy. We also investigate on the accuracy, and we published this paper in International Orthopedics last year of our first 100 cases of the department with 2 years follow-up to understand the complication and everything. And you can see that the precision for MPTA and PPTA is around 1 degree. So this is the precision of the guide, which is not 100%, but very close to something which always target the good correction. Is it safe? Same publication. You can see that we have some hinge fractures. So every patient were CT scanned at 2 months after the surgery, and you can see that we have a high rate of Takeshi 1 fracture, pretty low Takeshi 2 and 3, but still we have some complication in terms of graft ortholysis. We were using cement, phosphocalcic cement. We completely abandoned that because we have tons of problem because of that. And we have some hardware removal because this plate is of course, always too big of a 30% removal rate, mostly because patients don't want to have a plate below the skin more than really medical reason. Safe last year, which was completely crazy, wrote more than 10 papers in 3 months in my department. We discovered that this key wire that at the beginning was positioned to fix rigidly the PSI to the bone helped us first to protect the hinge during the sewing process, but more than that, protect the hinge during the opening process. And most of the fracture were done because of we opened too, let's say, too harshly the gap, and having this key wire inside enhance the ability of the hinge to resist to fracture by 800%. 800%, that's the real numbers, both in cadavers and in clinical settings. And the number of hinge fracture just were divided by 2 just because of this key wire. We are not leaving it inside at that time. Now, like Kristian and Adrian and Rags are doing, we are putting some screws inside of the tibia on this key wire from inside out to fix the hinge after the surgery more rigidly. But at this time, even having just this key wire divide the number of fracture by 2 in a very easy manner and very cheap manner. Is it time sparing? Good question. I would say that this is my this is the last slide of my planning provided by Nuclip for this kind of osteotomy. You can see that I know my correction, and more than that, I know all the screw length. I know which plate I'm supposed to use. So basically, when I'm opening the skin, every screw is already open in a small device, which is helping us to know where the good screws are. And everything is open, so we are earning maybe 2 to 3 minutes for each cruise because everything is so ready, and everything is done and on the table before the beginning of the surgery. Additional procedure, so I just show ACL here. I know that it is one of the reasons that this system is working very well in the US, because it's not so easy to do an opening wedge osteotomy plus an ACL procedure. Even though it's pretty frequent to have some varus in the revision ACL process, for example. And we all know that slope and varus are 2 main issues for ACL re-rupture rate. So correcting that is, of course, pretty obvious. And you can see here that having this ACL tunnel in between those 2 screws is not so easy doing freehand. So this is why we asked Nuclip to provide us a tunnel, a driller, which is connected to the guide, connected to the plate, that allow us to have the ACL footprint defined on CT scan and the plate at the good spot. So it's avoiding any problems. We will publish this with the team, Adrian, Chris, and Rags, in arthroscopy. The paper is accepted, not out on PubMed today, but it will be in the next days. And this is how it works. So it's a shooting we performed with Chris in a cadaver setting in Nantes some months ago. So this is the first generation of PSI, which is pretty big. To be honest, it's impossible to use it without detaching completely the hamstring from the tibia and reattaching them at the end of the surgery. So to have the guide correctly positioned on the tibia, it's mandatory to remove them. Then, as you can see here, we are protecting the MCL, which is released but not completely cut from the bone. So it's still attached at the posterior aspect of the tibia. We are inserting this PSI posteriorly and anteriorly. There is clearly only one position in the bone. It's patient specific, so it's not. It's pretty easy to find the good one. Even though we are, you will see, we are verifying this on the fluoroscopic X-rays. As you can see, and as we discussed, this is a classic common retractor 3D printed. We are inserting it below the MCL, more posterior. scratching the posterior aspect of the tibia to be sure that we are protecting completely the vascular bundles, and it will still stay here until the end of the surgery. First key wire to drive the saw blade and to be able to be fixed. Second key wire to be to protect the hinge. So the first one you can see is is horizontal and will be driving the saw blade inside of the bone with this small saw tracker. The second one is ascending, and it will be positioned to protect the hinge from sawing and protect the hinge from during the opening process. We are doing a fluoro to be sure that the position is a good one. Then we are drilling all the holes proximal first, locking the PSI with some blunts, big key wires, 4 millimeters key wires, blunt one. Then we are moving distal. We are starting the cut completely. We are not risking anything because of this protection. So we can we do the cut deeply at the beginning. We are removing the upper part of the guide to finish the cut and do the biplanar cut. So you can see here, we are leaving inside this distal aspect. We are cutting the posterior aspect of the tibia nearly freehand, but the cut is already started. And then we are doing the biplanar cut here to finish create the opening. We are using chisel. You can see here, very important, the distal key wire is still in place until the end, until the plate and the graft is positioned. We are just redoing the hole with those big key wire to be sure to find them when the plate is inside, because when the plate is inside, it's not always easy to find them back. So you can see here, I'm marking them very hard. Then we are using chisel to create the opening. Classic chisel, graduated chisel to open the osteotomy site. We will use a small triangular wedge to stabilize the opening before using finally a laminar spreader that you will see at the end. So we're doing the opening. We are fixing the osteotomy with this small triangular wedge to be able to go to keep it stable. And then we are putting the laminar spreader behind the MCL to slowly open until the hole are facing the plate position. When the hole are facing, and it needs to be very easy to insert, the plate is its position. We are putting the screws and we are attaching the hamstring at the end, and the surgery is done. Last thing to be done, we are removing the key wire, the distal key wire at the last part of the surgery to be sure that the key wire played its role of protection until the end. Take-home messages for this. Once again, it's only helping your hand and not your head. Remember, the planning is the most important step of the surgery. Draw angles, draw lines, measure everything. It's very important. It's very easy to use the PSI. After 1 or 2 cases, you will probably say there is no way back like I did. You will earn time, so you earn money and everybody will be happy. The price of the system is not so expensive. In France, it's still like 200 to 300 euros. And I'm earning 30 minutes of surgery, so I think it's worth it. And finally, it's a surgeon-specific instrument. You can start doing crazy Shiba osteotomy with it. This is some of the last PSI we create with new clip for very specific reason. Slope changing for a Blount disease, post-traumatic plateau elevation only on the medial side, meniscus transplantation plus PSI plus osteotomy, slope changing again, slope changing, Shiba osteotomy, derotation osteotomy, post-traumatic cases. And this is my PSI today. I call him the BB Yoda because it's very famous because of the new Star Wars series. This was my first closing wedge osteotomy PSI some years ago, 5 years ago, and now this is the size of it. So you can see that I removed the 2 distal screws and it's very smaller. It's allow me not to remove the hamstrings, and it allow me to pass from 10 centimeter to 5 centimeter incision. So it's, of course, I've been doing more than 200 osteotomy with PSI today. So it's easy for me to say that I know exactly how to position it, but I start with those opening and closing wedge PSIs, and now you can see that the new version of them is very small and it's pretty close to what Kristian is doing with the ghost, the ghost driller for the plating. It's almost as small as this driller. There are some papers around if you want to read about this PSI concept. I think we publish 10 to 15 papers in the last 2 years on this technology. And I'm very happy to discuss if you have some question around this concept, which I deeply love in my daily practice. Thank you, guys.
Thank you, Matt. Indeed, a eye-opening presentation.
It's really good.
Yeah, absolutely.
So,
two questions coming in, and then Bhushan. One question is,
yeah.
Matt, in the very first X-ray which you showed, there was a staple on the lateral side. So why did you put a staple on the lateral side, Matt?
Very good question. Because it was a derotational osteotomy, so there is no hinge. I completely cut the distal tibia to derotate from 20 degree the external torsion of the tibia. So usually when I'm doing that, I'm adding an external staple to have a double fixation, medial and lateral. Ronald van Leeuwarden, which teach me how to do those derotational osteotomies, is doing the opposite. He's doing a lateral plating and is securizing the medial side with a staple or something else. But I will say without any hinge and a very distal cut around the tibia, it's better to have two fixation process than one to avoid any complication and to allow patient to weight bearing on the system at 3 weeks.
Now, what we could understand that you put a hinge K-wire and then you take a saw blade. So saw blade would sometimes hit the K-wire as well. Yeah. So it might. Good
point. Yes.
Yeah, it may make the K-wire a bit weak, and then you open the hinge. Have you had a K-wire or the hinge wire broke someday?
Not actually, because it's 2 millimeters Q wire, and I will say that it takes time to cut it completely, but it happens. It can happen, let's say. But what happened, which is very amazing, is when you do a big opening with this Q wire inside, it's bending.
Yeah.
So you can see the Q wire is completely bending, and this is how we understand that it was absorbing strains. So all the strains that usually happen in a hinge are absorbed by the Q wire. We published this in Clinical Biomechanics some 3 months ago with Chris and Adrian and Rags. And it's absorbing like mostly all the strain that are passing from the wedge to the hinge, because a single very common Q wire is in the middle of the problema, which is an opening that just want to propagate onto the lateral side of the knee.
Okay, perfect. Yeah. Bhushan, any more questions?
No, I think let's finish the talks. It's already a bit late, so let's go to the next talk if it's all right.
Yeah, thank you.
Yeah, no problem. Absolutely. Yes, Matt.
Thank you. I've got a bit of feedback actually. Can you hear me okay?
Yeah.
We can.
Good stuff. Lovely. So I'll just share the screen. Hopefully you can see that now, yeah?
Yeah, it's well visible. Yeah, perfect.
Fantastic. Okay, so lovely. Thanks very much for the invite, Bhushan. Really good talks and really enjoying them. It's kind of back down to earth with a bump after that fantastic talk by Matthieu now to talk about complications. But hopefully a slightly different spin on just the sad old, sign of all the things that can horribly go wrong, and maybe a little bit more towards, the philosophy of change and improvement and how we guard against complications. So a little bit more perhaps on the sense of avoidance. So I'm just trying to see my advance. There we go. So really, it's kind of lessons learned from my experience of over 750 osteotomies and how we can use complications to prepare and get out of trouble, and really how you go about setting up your practice and how you learn. So what I've done is just talk a little bit, or what I'll do is talk a little bit about general setup, but then I've divided complications into a kind of a dashboard, which will hopefully emphasize and illustrate a little bit better. So the most basic thing really I can say is please collect your data. Everything you do is kind of lost or loses a little bit of its value if you don't put it against the backdrop of collecting all of the information together. So if you don't have a registry, make a registry or try and get consensus by joining together with others. because only by getting the big data are we able to estimate complications and work out solutions. So, I mean, I commend you immensely. Just get a visit in, you know. I'm not suggesting everybody goes to Kristian because he hasn't got enough time to deal with millions of people, but every one of us is very, very happy to take visitations. And there I am with Philip Lobenhofer and Kristian in Hannover last year with a couple of colleagues from the UK. And it's not just learning about whiz new techniques, you know, it's the most mundane stuff that you take in. The setting up of a patient on the table, where you put the foot roll, where you stand, where you're going to have your assistant. And the assistant is so important. You know, there's my assistant back in the UK. You appreciate how important it is to actually have good assistants, good theatre staff around you, and how much the team contributes towards the overall effect and the overall outcome. It's so important. And you kind of understand these things and you learn really by osmosis, by going on a visitation and just taking it all in. So I couldn't commend that highly enough to you to do just that. So looking at complications as a whole, I've designed this dashboard really to give us an idea, because the consent form itself, many of us could regard as a risk in its very own right. How do we approach this? The consent form asks us to talk about the most severe and the most common things that happen. Of course, they're not the same or mutually distinct. What's going to kill you? Well, a fatal pulmonary embolism will do that for you, but it's very rare, fortunately. Vascular injury might lead to an amputation. Hinge fractures can be a real ball ache and can lead to non-union and issues with healing and second operations. Infection, fortunately, I don't think is such a big deal, but we need to talk about it and we need to understand it to deal with it. And then at the other side of the spectrum, I think there is a less recognized area that we need to scratch the surface a bit and really get used to. And this is where this wonderful philosophy with PSI and other systems can help us. So when it comes to VTE, well, what we found is there's not much evidence there at all. This systematic review is probably the best thing out there, and it reflects my practice with DVT incidence at about 1% and P perhaps at about 0.1%. But the evidence we use in NICE, which is our national guidance in the UK, is not particularly helpful when all we get is consider VTE prophylaxis when doing an osteotomy. And this reflects the lack of scientific information. I went around a lot of colleagues a couple of years ago and we got a consensus from what people were doing. And happily, most of us do regard VTE prophylaxis as an important part of the consent discussion. Most of us have a standard protocol and most of us use chemical prophylaxis. That regime is usually somewhere between aspirin and low molecular weight heparin. And all of us, bar a few at the bottom, seem to recognize the importance of the mechanical regime as well. There's a split between those who feel that there's a difference and who knows the difference, but there's a general feeling that arthroplasty is more risky than osteotomy for VTE, although a large number didn't commit themselves. So my advice regarding VTE and from all my experience is that basically there isn't the magic bullet and you're very wise to stay with the herd as it regards things as I've shown you. Use a chemical prophylactic agent, use mechanical measures, and please let's collect the data. Vascular injury, well, of course, this can be really serious, and we've spoken at various moments throughout this webinar regarding potential complications of this sort. It's not necessarily apparent at the time you do commit the offence that this has happened, but you might see this finding post-operatively with a pseudoaneurysm. You can also cut through the bone and then do something horrible after you think you're out of danger. You can put a nasty sharp bit of bone substitute in and cut the artery off, which is what happened here, leading to huge comorbidity. Paper just published suggests a common sense approach. And again, Kristian has just been talking about the retraction and the MCL and how we approach this. Well, this is a basic bit of science with 45 computerized angiograms reconstructed, and essentially points out that there are effectively different directions you can head, and you can be much safer if you head in front of the fibula than at the fibula or behind. Of course, there should be a retractor there, but if your assistant is dozing on the job and the retractor isn't there, you're much better off having that saw cut in the right direction. As regards that aberrant artery, I'm sure it exists in 2% of cases. That means I must have met it in more than 10 occasions. But I have no acute vessel injury in my practice. And I suspect the difference there between Kristian's account and my own is that I use a tourniquet and I apply a bandage before letting the tourniquet down. And I'm not aware of any compartment syndromes, any issues caused by that vessel, which I'm sure does exist and does cause problems sometimes. This question of technology or technique, on the left, the precision saw, strongly recommend this. It's a great device. I use it now regularly. It's got a great feel to it and it helps my surgery. But it's no substitute for technique. And I can tell you that there are arteries, I'm afraid, being cut using the device on the left. It does still happen. So it's technique and technology. Hinge fractures, we've talked about this. Takeuchi has done this classification. This is a type 1 fracture, obviously not fixed properly, poor plating, poor rehab, and it's fallen to pieces. This is a type 2 fracture, and with the right rehab, this patient got away with it, the surgeon got away with it as well. But it doesn't always occur, so be careful. The type 3 fracture, this is one of my patients. Why does this occur? Well, this occurs because of poor technique, and this is a different patient where I've used this as a model to illustrate. So look at the incomplete posterior cut at the back of the tibia. If that's the incomplete cut and you try and open that gap, then what's going to happen? Well, I think you can see what's going to happen. That's going to crack and you're going to get an intra-articular fracture. And that, back to the patient again, is what's happened here. So what you have to do is take that bone spreader out. You have to reduce the osteotomy, reduce the fracture, and you need to put that interfrag screw across, compress, and then put the buttress of that plate onto the osteotomy. And that's it. It's 6 weeks after surgery, and it's healed beautifully. And this is the hinge wire technique that we've seen described already by Matthieu in his brilliant presentation and by others earlier. And this is obviously a very important part of the construct, I'd imagine, particularly for the larger openings. And you can use that wire when you're doing a femoral osteotomy, as Kristian's already illustrated, and it's following my visit to Hannover that I've incorporated this as a regular feature of my practice. And you can introduce this wire, which abuts. Here, this is a lateral closing wedge, but you can do it for both lateral and medial wedges. This is the saw blade, the precision saw blade, clearing out, just scooting out all those little edges and fragments, and then careful, slight distraction, slight flexion, and bringing the osteotomy down to its close. Then we put the plate on. So when would I use a double plate? Well, I think that's important in certain situations, certainly in the revision situation, when there's been complete loss of the hinge in the primary, and more I'm using it in the female gender. And as we push the envelope and we're doing postmenopausal ladies, then I use that in this situation. Infection. Well, infection is something that is, I'm afraid, in the literature, not brilliantly explored. Look at this systematic review, which shows such a wide range of incidences. So I've looked at my own series of patients, and we're currently doing this again now, but a couple of years ago, we had over 400 cases to look at. We did a lot of this prospectively, but re-examined through hospital readmissions and case note scrutiny. We saw 19 revision and 417 primaries, and we got an infection rate of 2 from the revisions, 4 from the primaries, giving just under 1% primary and 10% for revisions. We didn't find any common theme for the bacteriology, and all implants we removed at 8 months, and all with the deep infections were treated by a washout at the time of surgery. And there's been no ongoing issues with osteomyelitis or any problems in the patient who was revised. So looking at the right-hand extreme of our dashboard now, we've got joint line obliquity and inaccuracy. Now, I would consider these as 2 different concepts when we were addressing this. I think they're less obvious. You don't stop halfway through an osteotomy and go, my God, there's some joint line obliquity, as you might if you'd pronged the popliteal artery. So this is not something that is necessarily a red raging flag that we'll see at the time, but it's very relevant. So joint line obliquity, and already we've touched on this through the lectures we have already heard. But this is a patient I operated on 8 years ago, 54-year-old, did a big correction in the tibia. And you can see that the coronal plane alignment, mechanical axis, looks fine, but it's not a good overall outcome for me, because this medial proximal tibial angle, the MPTA, has changed from 84 to 98. And therefore, you can see if the patient wants to plant their foot with a horizontal joint line, it's going to be a very awkward gait to achieve that. So this is not a brilliant result. And even though the patient got 8 years, I would classify this as a complication, knowing what we know now. And I think we should really be keeping our MPTA to 94 or below. And this patient is now going for a TKA. So that brings in the double osteotomy. This is what we should be doing more and more of. It addresses the deformity at the appropriate levels, reduces our joint line obliquity, gives us normal gait patterns, and encourages, and we're seeing very encouraging early responses. So we got this data from David Elson, who looked at the recent stuff on the UCOR osteotomy database, and we saw double osteotomies, small numbers, but still double osteotomies giving great early results at 2 years for the change in the OKS. DFO was giving us similar, but not quite as marked. And similarly with HTO, we're getting good retention of improvement without this being a particular difference to the degree of the doubles. Stephen Claes from Belgium has looked at the systematic review of intended target of correction and achieved. And looking at the yellow bars, this is where surgeons, the authors, have tried to correct to, and the blue bars represent the outcomes. So a big difference there in terms of intended versus achieved. And we saw from our UK data that undercorrection on the left was often followed by, in early results, by failure with early revision, less so with overcorrection. And one of the big problems, as we've already spoken about, is this correction inside the joint. And as Kristian said, we cannot know for sure what's going to happen with that correction. We can try, and we can use his technique, which is very effective in the main. We found that our United Kingdom results were skewed so that about 1/3 were outside of 10% accuracy. Now, I think things are better now, but there still are, as we all know, some outliers which surprise us. So this allowed me the opportunity to indulge this particular opportunity, which was fortuitous for me, to see what we could achieve with post-operative correction. And we have this device which was predicated on the precise nail, which is used for corrective surgery in limb length discrepancy. And we used this for our osteotomy, our medial opening wedges. And our first 10 cases, we saw this, the 10 results on the left-hand side, 9 of these were within 5% accuracy, and the final one was 6% accurate. So great results at this early stage with HTO. And we can see at the tip over how the JLCA changes, in this case from 4 degrees to 1.5 degrees, just with that small correction, shifting the weight bearing from medial to lateral. So we thought we would look at my double osteotomy cases. And so we saw 44 doubles, which we've done over the recent years, and we excluded the 12 valgus malalignment patients for whom we can't use this device. And we compared the 13 using a nail and plate with the 19 who'd had double plating technique. And this is what we saw. On the right, we had the revised double plating extreme, but overall, we've got a significant difference for those using a femoral plate and a nail compared with the double plating technique. And I think this reflects the variability in that the hypomoschlion, that intra-articular effect that we see. So in summary, I would say that the most important message really is to know your results and collect your results and build big data. Teams are so important, and you know, we're a big team talking today, and we all talk to each other and share ideas, and this is a fantastic way of improving results. I think DFO and then double osteotomy is so important now in terms of realizing the potential for this type of surgery and employing it regularly. Our technique is very important, and as well as listening to lectures, there's nothing quite like getting into the cadaveric lab and learning with the experts. So although we don't have a Northern Osteotomy Masterclass this year, we're hoping to have a webinar in July And when things get back to normal, I'm looking forward to us getting these things back in score again. So thanks very much.
Yep. Thanks, sir. That was an amazing talk. Bhushan, are you around? Can we unscreen and share the screen?
So stop share.
Yeah, stop share. Yeah, that's perfect. That's perfect. Yeah, Bhushan. Bhushan has gone to sleep. Bhushan, can we have Adrian's presentation and then we have some questions so we can ask the panel at the end of the Adrian's presentation? I think. Yeah, I think. Yeah, Adrian, we can start with you. You need to unmute yourself, Adrian.
Yeah.
Yeah.
Okay. Can you hear me?
Yeah, now we can. Yeah. Yeah, we can. We can.
Brilliant.
Yeah.
Okay, so I'll try and rattle through this because we've been going for some time. But thanks so much for the very kind invitation from yourself and Bhushan and from the team at the IAS. Great privilege to be. As you know, oops. Oh, there we go. As you know, I had a lot of fun when I visited in 2014. Came to your facility. We had a lot of fun together there. We then went down to Hyderabad for the meeting and did some lovely live surgery. And I felt
Adrian,
like
possibly,
yeah.
May you hear me? Possibly go to leave the presentators mode to full screen.
If you click on use slideshow, that might work, Adrian.
So what was that? What was that, Rags?
So if you go to share screen and then change it to use slideshow rather than presenter mode.
Okay.
Top left, perhaps.
Yeah.
And then bottom.
How's that looking? Can you see that?
Better. Perfect. Yeah.
Perfect.
Okay, so Hyderabad, as I was saying, we visited you, IPS. We had a fantastic few days in Delhi. Then we went down for the meeting and did some lovely live surgery. And as I say, I felt like a king, the Maharaja down there. And then the following year, Delhi and Thailand, we did some more great live surgery, a lot of fun. And they were two really great experiences for me. Obviously, Sachin's meeting is fairly amazing in terms of the numbers. Last year in India, some very nice breakout sessions with Ronald and Bhushan. Again, some nice live surgery. So we need to offer our patients the best solution. And one of the problems we've got as orthopedic surgeons is what do we do with the so-called treatment gap? Physio, injections, bracing, more injections. Come back when you're old enough for an arthroplasty. And that can be a big problem if you're under the perfect age for an arthroplasty. And then, of course, is a knee replacement the correct solution? Not always. We should, in many cases, be considering, even in severe grade 4, not perhaps the extreme that you see there in the 85-year-old, but in bone-on-bone arthritis, we can get a very good result with an osteotomy. Slope is becoming more and more recognized as a key to how we manage our patients with ligament instability. And we need to think about osteotomy as an adjunct for meniscal and cartilage surgery. So total knee replacement, we know, is a worry in terms of outcome because patient satisfaction is not as good as we would like. We have the problem of a proportion of patients, having a bad outcome, perhaps 10% delighted, 70% happy, 20 to 30% not happy. And the outcome can be really very bad, and we all know this. We also know that there's a failure rate with knee replacement surgery. This is the Baylis paper from last year, 65,000 patients, minimum follow-up 10 years. And the key take-home message from this paper in this thousands of patients was that if you're under the age of 55, the mean time to revision for a knee replacement was 4 years, which is obviously a disaster. So osteotomy is key. We see here past present Raman Sales, fantastic slide about keeping everyone in the green zone, which is where we want to be, with osteotomy being at the limit of that. So we wrote this paper, I've shown this slide a few times, dividing osteotomy surgery into historical early modern years and modern latter years. And I want to concentrate on present day, because many surgeons sadly are still stuck in this historical time that doesn't exist anymore, and we really moved on. Alex Staubli, Professor Jean-Claude Poudou, Alex Staubli, Ronald, Kristian, Philip Lobenhofer have brought us to where we are today. And we know now that the results of our surgery are very good. When we look at the HDO survivorship, a very high survivorship at 10 years in meta-analyses that have been carried out. We know from Lobenhofer's paper and the other multi-centers that got together in 2013 with a very nice series of 533 patients, excellent survivorship in this paper. And we've recently published our 10-year survivorship for DFO in 91 patients at 10 years, 89% still surviving and doing well. So we know this works very well. It's a very powerful tool and one that we should always consider. So what about some cases? So grade 4, can we really do it in grade 4? This guy, he's a 44-year-old mechanic. I'm just gonna make sure, yeah. He is really struggling. He can't do his job. Video's not playing. He can't do his job. He's grossly varus and needed a double, or actually on both sides. So that's what we did. We went ahead. We did look at the grade 4 arthritis that you see circled here. He went on to have, within an 8-week period, 2 double level osteotomies, and he's now back working as a mechanic with no pain, or very little pain, absolutely delighted with his outcome. And we show these x-rays and surgeons say there is no way that you can make this work in such an extreme case of arthritis. And we can, and it does, and it's something to consider, particularly in these young patients. Here's an extreme case, a 56-year-old, grade 4 lateral disease, range of motion 20 to 120, in tears in the outpatient department, absolutely at the end of her tether. She's a young, fit lady. She used to like going out on a bike. We did a lateral, we did a medial closing wedge, and she regained full movement in the knee. She came to see me after the plate had been taken out this week, actually, which is why I put it in, and she's back cycling. She's a year down the line, and she's absolutely delighted with her outcome. So grade 4, you must consider osteotomy as a very useful tool. So we have Ronald as a secret weapon coming to join us now. He is at our osteotomy course with Bhushan moderating and helping with the surgery. And Ronald has come and done a number of rotational cases with us. And as we all know, these patients have lower limb problems. They have hip pain, they have groin pain, they have foot and ankle pain. They often see many surgeons, they get many different treatments, and often a lot of unnecessary surgery before they come to definitive treatment, if they come to the right surgeon, that is. And we know that this is not something that we're taught and find easy to understand as orthopedic surgeons, because it's not usually something that comes into our clinical practice when we're training. This is one of Ronald's patients. I don't know if the video will play. She has severe kneeing in. She's only 17, pain for 5 years, many opinions, came to Ronald as a fourth opinion because of knee pain. Completely neutral. You'd think she was valgus, but this is a torsional case. So when you actually put patella forward, you've got a straight lower limb. He does the analysis, and actually she's got gross external tibial torsion. He does what for him is a very simple case, and actually having seen him in action, we're growing in confidence with this surgery. This is a 50-minute operation for Ronald, a single level derotation of the tibia, and then we can see the patient walking very comfortably 3 months down the line. And this has been the experience with the cases that we've done in London. So here's another case, miserable malalignment, a 27-year-old young lady with progressive left anterior knee pain. We found torsion in the femur, close to 35 degrees, tibia, the indices were off. So when we did the correction, it made her tibial torsion obviously much, much more extreme. So double level derotation osteotomies in the femur and the tibia. And you can see the intraoperative pictures, first the femur and the tibia, finding the right plane to make the cuts. This is actually a friend of hers who presented, sorry, the videos aren't running, with exactly the same issues, miserable malalignment. And here you see us operating on the tibia together. We do this as a team, similar procedure. Here we did an MPFL as well. This patient went on to do extremely well. Here's a very interesting case that we did. This is a 44-year-old gentleman in an RTA, lateral tibial plateau fracture, ended up with pain and valgus, had a derotation combined with a varization. And actually, this just very subtle changes in this patient's alignment made him a very happy and delighted person, having lived for several years with severe pain. Another interesting case here, we bring in the slope. So this patient had two problems. One was with his knee and the other was with his foot. He had Charcot-Marie tooth. He had a hindfoot deformity, and because of his valgus, the very on the ball foot and ankle surgeon said, you've got to get your knee straightened out, your leg straightened out first before we can tackle your hindfoot issue. So he needed a DFO for this. He previously had strange surgery by another surgeon that didn't really help him with his distalization procedure. And we did a combined DFO combined with a slope change using this technique. So first we come in, classic closing wedge on the medial side of the femur to varize, and then we came in from the front. We used Ronald's technique that he's published on, where the extensor mechanism is taken away, and we created a wedge in which we opened at the front of the tibia to increase its slope. We fixed then with a series of small fragment screws, fix the tibial plate, fix the tibial tubercle as a plate, and supplement with staples. And here we can see the alignment post-op. He's about to come in for the second side. I think COVID is what's holding him up. Next week or two, we'll be tackling the left side. And we can see if the videos run, this is him at 6 weeks, relatively pain-free, actually very much pain-free. This guy's hard as nails, and a very nice range of motion at that early phase. Final case, this poor chap, under the video will work. Yeah, this poor chap had a medial tibial plateau, which was fixed in a grossly malunited position. He actually had one of the screws was in his joint. He'd been living with it for several years, a young guy, 37, felt he's got 2 young children, was really struggling to run his business, which is a very physical job, and came to us with this malunited medial tibial plateau fracture. Here on the CT scan, you can see the extent of the osteonecrosis and the failed or failure in the attempt really to reduce this fracture, and then of course the osteonecrosis that then ensued. So the procedure was first of all to remove that hardware, then to excise the medial tibial plateau, fashion a graft from an allograft, do an HTO to offload, and then fix the graft in the HTO. We also did a distal femoral osteotomy just to get the alignment correct. So it was a double level case. So here we can see the dissection coming through the previous incision. We've removed the plate. We then marked out the osteonecrotic area, or I should say Ronald did, with K-wires, which we then excised with a combination of chisels and the saw, just to kill that. This is a very much an eyeball operation, and not one that I was happy to take on. It was amazing to see Ronald do this, and he's got 3 or 4 very similar cases that he's done. And we then, this is the allograft that came, the interesting bit for us obviously at the top, let me get back to that. And we fashioned the portion of the medial tibial plateau that we needed to insert. You can see it here coming in temporary fixation. We then went underneath, did our osteotomy. You can see the femoral osteotomy in place. You can see the weight-bearing axis is nicely into the lateral compartment. And here, I believe this is 5 months. We're getting to see some nice union. This gentleman's absolutely delighted, doing very well. We're just chewing that along and see if we get the size. But yeah, we're starting to see this heal up very, very nicely. A happy patient. And again, you'd think this was horrifically painful, but actually, this patient came to us in the early phases. Let's kill the volume. And these patients, you know, they can move quite well early. This is at 5 weeks, straight leg raising and moving pretty well. And then if we go to the view at 5 months, we see the femoral osteotomies healed really nicely, as I say, beginning to heal nicely in the tibia, and he's moving comfortably, and his back being active, although he's put on a few pounds since the start of all this process. I want to finish by saying this is the surgeon's choice. You know, I'm talking about the power of osteotomy. Mark, well known to many of us, a very famous and well-known knee surgeon from South Africa. He chose an osteotomy. Joshi, in his 40s, underwent an osteotomy for his left lower limb issues. Died from the Middle East, the same. So this is the surgeon's choice. You've seen this before. Please come and visit us in London. We've really set up a good centre for osteotomy. We now have, I think, 40 to 50 cases on the list that we'll be doing over the next few months as we catch up with COVID. And of course, our academic arm in Marseille with Olivier, who's pumping out papers at an amazing rate, and is also someone that's really worth a visit as a partner to our team. We'll be throwing our second course in London. It might not be the 4th and 5th, it might be towards the end of February now. It will be a lot of cricket themed around cricket, because it will be at Lord's, and there'll be a great venue and a great group of speakers. So thank you very much for allowing me to speak today. That's the end of the talk.
Thank you, Adrian. Indeed, the cases which you showed was absolutely amazing. One question which has come: if you just need to do an isolated tibial slope alteration, do you do a subtubercle kind of osteotomy, or how do you do it?
Yeah, so the way we've done, I think between myself, Matt, we wrote up, I think Rags, when he was a fellow, I think he wrote the paper. I think there were 12 to 15 cases, and for those we all use Ronald's technique, where we take off the tibial tubercle. So with the osteotomy, is one I preferred earlier. We take off the tibial tubercle with a flake of bone, with a long enough piece of bone that we can bring it up out of the way. Then we can approach from the front and either remove a wedge or create a wedge to change the plane, and then fix with two staples either side and a series of screws to fix the tibial tubercle. Now, in a recent visit, and sadly we didn't capture it with video, but the Svengali of osteotomy, Kristian Kley, showed us this amazing procedure where actually he went around the tubercle. So he left the tubercle attached, and he made the saw cuts up and completed with a biplane underneath the extent that, leaving the tubercle. The tubercle was still attached at the end of the procedure. So this was a very, very clever technique that I'd never seen before. And actually, that patient had, in fact, that was Andrew Rubin's second side, wasn't it? It was, wasn't it? Yeah, that was Andrew Rubin's second. So Andrew Rubin, the guy says coming up, he's been done. Second side was done by Kristian, and actually he felt much happier when we met him the next day to say, you don't need to protect your extensor mechanism, you don't need to go into a brace, and he mobilized extremely quickly as a result of that.
So he was fixed just by 2 staples then.
So Kristian said to us, we don't need to fix this guy. We put wedges of bone in. He said, leave it. He said, if you're pansies from the UK, maybe you could put a couple of staples in. But he was saying, leave it. But we put 2 staples in. We weren't strong enough to just go with the bone blocks.
Absolutely, that's the amount of confidence. So Pratik, do we have any questions? Sundar, Bhushan?
Yeah, I just want to ask one question to everyone. How much FFD can you tolerate with your osteotomy? So how much FFD can you correct with your osteotomy? It's a question asked by Raghu Reddy to me as well.
Yeah, I'm on, so I'll just quickly say I think you can only correct FFD in the tibia unless you do a separate osteotomy in the femur from the front. So if you're trying to, it's a very clever trick, because a lot of these patients come with a little FFD 10, 20 degrees is doable. But it all depends on how big your osteotomy is. So if you're doing a 5mm opening wedge, you've got very little to play with in terms of your ability to correct the FFD. You get rid of 10, you get rid of 10, maybe even 15, absolutely max. If you wanted to correct a significant FFD beyond that, you have to be doing a significant osteotomy. That's my take on it. It needs some math. Matt, what do you think with all the work that you've been doing with PSI? Have you got a formula for this, or?
Not really. I would love to say, but no.
Okay.
No.
Okay. There is a case which one of my delegate wants to share. He's just putting online. Just have a quick look and give us your opinion. So this is the case here, if you guys can see this. And if Mukesh, you can speak as well. Or Sandeep.
Sir, yeah. Dr. Mukesh has posted this on YouTube and he requested if he can discuss with the permission of all the faculties. So he has written that he has a female with genu valgus, 21 degree valgus, ML DFA is 80 degrees, MPTA is 101 degrees, JLAC is 1 degree. How to plan both DFO oblique HTO, both medial closing wedge. I'll just share the canograms. The first X-ray, the second X-ray. He has already done the markings. He just shared with me. That's the, again, calculation of the angles. So for the left side, he wants to do both osteotomies on femur as well as tibia, closing wedge.
Yeah, I guess that's a smart idea to distribute it to both bones. So, I mean, both are by 10 degrees out of the range. So obviously you have to go to both bones. Otherwise you overcorrect the other by 20 in the contralateral direction. So that would be a correction which is contra-anatomic on purpose, if you'd say so, rather a palliative surgery. The only thing that you can achieve is getting mycolich line right, but the joint line orientation will just be tackled if you distribute it to both levels. So you have to do that. In my hands, as I close every femur, or almost every femur, you should never say never, but that's a closing wedge from the medial side for me, and obviously for the tibial side, it's the same. Obviously you spare some bone, and we could argue on that length discrepancy after the surgery. And you might say, if you make a double level closing wedge, the limb is shorter after the surgery. I guess this patient has more severe problems than a shortened limb. By the way, you lengthen up everything if you extend it. So once it's straightened, it's longer than it is right now. So you will win more length by straightening it than by the resection of the wedges. So this is a double level medial closing wedge in my hands.
Yeah. So Mukesh, can you ask the question if you directly can?
Yeah, I just want to know, I have just done all calculations through the Bone Ninja software which I have. So it shows me the lateral distal femoral angle of 90 degrees and the proximal tibia of 101 degree. So both sides, should I do 10 degree medial closing wedge or distal femur closing wedge and lateral opening wedge in the tibia?
Well, that would make sense. You cannot just say by 90, you cannot just now measure that it's 90 and then say, well, 80 degrees MLDFA and 100 MPTA. I guess that was what you've measured approximately. And yeah. But you cannot just say, I normalize these ones and bring them to 90 both, and that's it. So what I would do is I would make some kind of a stepwise individualized planning by making first the femoral cut in a standard Miniazzi session, and that could be either 9 or 11 degrees. I cannot tell. It's a matter of precision then, that you say, well, I want to bring that, let's say, to 88 MLDFA, and all the rest has to be then taken out of the tibia. This should be quite a straight forward case, as a matter of fact, because there is not much of uncertainty due to the joint line convergence angle here.
Right.
So you're completely you can completely rule out the third level of insecurity here, which makes it easier for you. I mean, that's a good case. The hardest thing in this case is removing the metal first.
So both closing wedge, medial distal femoral and medial proximal tibia, both closing wedge?
Yeah.
Okay.
Yeah, okay, perfect. So we have Sundar who has a question. If you can unshare the screen, Sandeep. Yes, Sundar.
Yeah, my question to Adrian, Kristian, and all the faculty. How do you differentiate, I mean, your indication for your slope correction osteotomy in recurvatum? How do you differentiate? Is due to the bony issue or due to the soft tissue issue in the posterior structures, like posterior capsule insufficiency? And how do you differentiate, and how do you do the slope correction? In which case you do the slope correction?
So I think it's a difficult thing to plan for, because there is the soft tissue elements, and I think therefore you need to bespoke it to the patient. And much easier and the more common is that if someone has got a negative slope, is to give them a slope, and you titrate how much recurvatum you've got, and when you have you plan it as to what you think it's going to be, and when you achieve that, you test where you are. And if you're still bananaing, you might continue. You don't want to overdo it. It is an operation that we don't have great, I don't feel, planning tools for at the moment. And I think therefore you have to be very careful, and you have to do a clinical assessment intraoperatively of what you've achieved. That would be my take on it.
Okay. Yes, Satish, you do have a question then.
Yes, so my question is to Adrian. While doing the femoral closing wedge osteotomy along with the correction of the rotation, how he hold the rotation, because many times the reduction get lost when we are correcting the rotation. So is there any tip how to
so he did show a biplanar osteotomy, Satish. He did show a biplanar osteotomy to control this.
Yeah, no, for the malalignments, we do uniplanar. Okay. And so we cut the bone on the tibia, we cut the bone on the femur. On the tibia, you've got the fibula, it's more stable. On the femur, Satish, you have to be careful, and you rely on the periosteum. And when you want to make sure that the limb is supported. It's not bananaing on a footrest. It's actually supported by the table. You want to have good assistance, and you want to go carefully with the rotation. You can, of course, apply an X-fix. And I think Ronald used to do that in the early days. So he would put his X-fix on, and then he would rotate. And when he was happy, he would take the X-fix off, and he would then fix. He would fix with the plate. He'd have done his rotation, and then he would take his X-fix off. We don't do that. We just go carefully, and we rely on the periosteum to allow us. Normally, it's around 20 degrees. It seems to be what we're correcting most of the time. And you have K-wires that then align, and when you've aligned at 20 degrees, you commit with your plate. This is definitely something that's going to lend itself to a PSI approach, and I think this is the sort of case where, I mean, you have someone like Ronald with huge experience who makes it look very easy, and he seems to get a very reproducible result. I think for people who aren't as experienced as him, and that's pretty much all of us, having tools like the Nuclear PSI, I think is the way to go, to be honest, with these cases. But he does come and visit and watch him, and he makes it look very easy, doesn't he, Rags?
He does. He really does. And I think the key is what Adrian said, is having the right support and the right personnel around you, but also using other techniques which are now available with PSI.
So thanks.
So maybe
I think, yeah.
I don't want to miss that chance. Don't want to miss that chance, because I guess we are close to finishing. But I wanted to talk to ask Matt Dawson, actually, because I guess he's the only one with experience regards this nail, and his feelings as far as dynamic corrections are concerned. Because I mean, what we do is definitive treatment. I mean, as soon as the patient leaves our table, everything is done and it's fixed. And I think that's really a great open field of dynamic control and possible post-operative options that we have here. And I've learned that basically from the colleagues who do Elizarov corrections. And I really came across this idea, and I thought it's really remarkable, because we were talking about the correct point of correction for ages. And well, there is scientific publications around saying it should be 70, it should be 60, it should be 55 or whatsoever. In fact, it can be way easier if you ask your patients. And this is what the Elizarov guys did by dynamic corrections. And if you ask your patient whenever you shall stop as a surgeon, because this is the point when it feels comfortable for the patient, most of the patients come around at 50 till 55% of tibial plateau width corrections. So these guys never had the idea of going to 70 or whatsoever. So what is your experience with double level osteotomies with a femoral correction, which is definitive, and a tailorable correction at the tibial side? I think that's a great concept, actually. And I would really love to hear your thoughts about your own series of 13 patients that you operated like that. I think it's remarkable having like more than 10 patients with a double level osteotomy, which is partially dynamic. I mean, that's insane. It's really crazy.
Of course, I mean, as I said, Kristian, I'm just very lucky. I think we're very lucky in this country that we've probably got people who are counting the beans who aren't really aware that I'm doing it. Don't tell anyone, by the way. This is very expensive, but it's exploiting my fascination and my interest, because I think we're only at the very dawn or very foothills of what might be possible, because you might be able to control sagittal, rotational, as well as coronal. And of course, you might also be able to play with the biology as well. And so, you will be fixed at 4, 5, 6 weeks because the biology will take control. But you can manipulate, as you rightly say, and you can ask the patient, and you can get a gait lab, and you can sort things out where you got everything at your fingertips, and you can make some massive steps forward. So, we're only at the very beginning, and I'm very happy to be able to exploit it now, reporting my findings. It's not easy for everybody to use this. And again, from what you've said and what other people have said to me, I don't think this actual manifestation of this principle is necessarily the right one. I think we probably need a plate which is dynamic rather than a nail. A nail is very off-putting for many people, but I think a dynamic plate might be even better. But I'm quite happy to keep this little pot simmering and just do my own little thing, because I'm finding it very interesting, and I don't think it's necessarily the end of it either.
So anyhow, I thank you for this part of the presentation, because for me that was today the biggest eye opener, let's say. And I think we really need to think of something. Well, there's something new and that you can learn every day. And the concept of combining dynamic and static corrections is not touched yet, we have to say. So this is something which is novel. And you see, osteotomy has a great surprise for you every day. Is not the end of the game, it's just the beginning. And we should all really try to put some more effort in that to get better practice for our patients. Great job. Thanks a lot.
Yeah, I agree, Kristian. There's so many new things we are learning from all of you guys, and it's such a great thing to have so many new points and so many new pointers about improving a surgical technique. I think we've all have learned a lot from all of you guys, and I really thank all of you from Indian Arthroscopy Society and myself as well for coming for this meeting. IPS take over now.
Yeah, that's okay. Thank you very much, Kristian. Thank you, Matt. Thank you, Adrian, for joining in. Thank you, all our friends. Thank you, Raghubir. I think it has been an excellent presentation. And Matt, thank you as well. You guys have really made a good discussion, and I must thank the panel here. And Bhushan, at the end, thank you for arranging this meeting. And we record all our meetings and put on our YouTube channel. So those members who were unable to see would be able to watch it later as well. So thank you very much, guys, and have a nice and a safe take care.
Bye-bye.
Thanks a lot.
Thank you.
Nice
Bye-bye.
weekend.
Thanks for everything.
Bye-bye.
Okay, so Sandeep, I think you can you can stop the YouTube live now.
Yes.
Yeah. And